nasal or an oral? Is it a nasal airway?
It's a nasal. It's a
That's impressive.
It's a transcranial now, but it was supposed to be. So yeah, most certainly, if you have somebody that has a basilar skull fracture, they can absolutely accidentally go into the brain. It's happened multiple times. So if you have somebody that you suspect that has a basilar skull fracture, give a ton of trauma to the face, try not to put anything into their nose. So. All right, so MPAs, again, measuring from the lateral edge of the nostrils to your lower wing. So basically the same thing for the OPAs, but instead of going to the corner of the mouth, you're just going to the corner of the nose. So that's what that is like. So you very appropriately suction this patient's airway. You do your head tilt, chin lift. There is SpO2 increases to 98. Respirations remain adequate. You transport him to U of L, where he spends the next forever in EXI before he sobers up, and he's turned the sandwich and goes home. Any questions about that case? Also, feel free to any learning points or any personal experiences that you've had. I know we've seen a ton of these patients.
Which nair do you try first?
Right? Does anybody know why? That's absolutely correct. Yes. Yeah, so the right nair is always, anatomically, it is sometimes a little bit larger. It's also it is also straighter, so definitely try that one first. That's a good
I think of it, you have 3 lobes of your lung on the right, and so that side's bigger. I don't know why I think of it that way.
More long, more nair. It's great.
Yeah.
More long.
More long.
How many of you have watched the sedation in room 9? So when the patient starts to desat, what do most of the docs do? If you've seen that, they do a jaw thrust, right? Why jaw thrust? Why not just head tilt chin lift? What is it about the jaw thrust that works so effectively getting people to breathe when they're under conscious sedation? Right? It's painful stimulus, right? So you give a jaw thrust, it's very tender. If you push back on the back of your mandible here, it's actually quite painful. It's quite tender, right? And so if I punch Dr. Lyons in the gut, what's the first thing he's going to do after that painful stimulus? He's going to go, and it's, right? yeah, he's going to punch you back.
But before that.
But before that, he's gonna inhale, and that's kind of the idea, right? So when you're not breathing, that jaw thrust, that moving that mandible forward, is causing a painful stimulus, and what that painful stimulus is causing them to, physiologically breathe, take a breath in, and that's exactly what we want to see them do when they stop breathing after a ketamine or reverse sedation. And that's why it's very effective, especially in airway maneuvers, and basic airway maneuvers, because you can get someone to stimulate their breath by just giving that little bit of a painful stimulus.
Absolutely, and again, that's why, going back to this slide here, that's why instead of kind of grabbing down the mandible, you want to reach back behind, because that's where the pressure point is, that's where the painful stimulus is, and so that's what's going to stimulate these patients to take a deep breath. All right, so moving on to case number 2. So you have a 75-year-old female. She's complaining of shortness of breath. She said that she was tired of getting up to have to go pee all the time, so she just stopped taking her 2 milligrams of Umax 5 days ago. I know that, especially as a medic, I knew the names of most medications. I knew what a lot of them were and what they were generally used for. I didn't really know a ton about doses. So in this case, I specifically picked this dosage because I wanted to kind of go over things. Sometimes knowing doses can kind of give you a little bit of information on the patient's clinical history. I know that all of our patients are extremely good historians and always know everything about their medical conditions, but in case they just sometimes don't, a patient who's taking 2 milligrams of Umax probably has fairly severe heart failure, right? So we all know Lasix is 40 milligrams. So a milligram of Umax is about the same as 40 milligrams of Lasix. So this patient, she's on basically 80 milligrams of Lasix every day. So she's taking a pretty hefty dose of nitrate. So there are certain clinical scenarios where knowing the dosages of some of your more common medications can give you some context of how severe somebody's disease is. So going on to her physical exam, so she's Ill appearing, she's able to speak in only 1 to 2 word sentences before she has to take a breath, so pretty severe respiratory distress. She's cyanotic. She's got 3+ pitting edema to the level of the groin bilaterally and Rayleigh nose around. So she's cyanotic, she's working to breathe, and she's crackly. So vitals, she's pretty hypertensive. Heart rate is 122, so tachycardic. She's tachypnic, and she's got a O2 sat of 78% of pulmonary failure. So what do we want to do next? I'm sorry? Nitro, yep, nitro and CPAP. CPAP. part of the cinematic universe. So what does it do? So it provides continuous positive pressure in the airways. It's the name, no mystery there. But what does that actually mean? So what it does is it increases recruitment of the collapsed alveoli. So these alveoli, they're made in pulmonary edema, they collapse, they stick together. So that continuous positive pressure tries to allow them to open up. It allows those alveoli to start working again for better gas exchange. And then extending those collapsed alveoli open, it also decreases the threshold that it takes to actually start to take the breath. So the way I like to think about this is if you have a balloon and the balloon is completely deflated and you try to blow it up, it takes a fair amount of effort to actually get that first part where it starts to come open. But if you have a little bit of air already in that balloon, it's a lot easier to try to get that balloon blown up, right? It takes a lot less effort. So it's basically the same thing for your alveoli. So if you can stent as many of these alveoli open as you possibly can, it takes a lot less effort, a lot less muscle recruitment to actually initiate a breath, and that significantly decreases the work of breathing, makes it where they don't tire out as quickly. So that's kind of one of the mainstays, and one of the reasons that CPAP is so effective in decreasing need for intubations. So who are the patients that we need to think about CPAP for? So the best evidence is for COPD and CHF exacerbations, especially in the really sick patients like this. There have been multiple randomized control trials that have shown mortality benefits in these patients. Again, doing whatever you can do to try not to have to intubate them is always going to be better for them. So CPAP has definitely been shown to be effective in preventing those intubations, helping them, and eventually helping them not die or become significantly third. So asthma exacerbations works great. Obesity, hypoventilation syndrome, something we never see. Neuromuscular disorders, so anybody who has any kind of dysregulation of their nervous system, so that's going to be multiple sclerosis, ALS, myasthenia gravis, muscular dystrophy. You can also occasionally attempt this on somebody if you are worried that they have a cervical spine injury, but the rare patient who is alert, oriented, able to follow commands, you can attempt CPAP on them if they have signs of independent respiratory failure. And then your drowning patients, again, pulmonary edema, so we just talked about the benefits of why CPAP helps in pulmonary edema. When not to use CPAP. So, unconscious or uncooperative. As far as this is something that I think there might be a little bit of inter-department variation as far as like when you can use meds on these patients who are not wanting to cooperate with CPAP. Very often the biggest thing is not that these patients want to fight you, it's a lot of times they are extremely short of breath, they get extremely anxious, and then now you're coming at them with a mask to put on, and it makes them feel like they're smothering. And so sometimes a little bit of anxiolysis we can use compared to all. You can in a pinch use benzos, although we kind of want to avoid that due to the respiratory depression that it causes. But like I said, just refer to your department's protocols for that, on whether or not you can actually do it if you get called in first. Obviously, copious uncontrolled vomiting or GI hemorrhage, so if they've got a bunch of stuff coming out of their mouth, you definitely do not want to put a lid on that. Inadequate respiratory drive, so if they're not breathing well, so part of this is going to be they're going to have to participate with this, so they're going to have to actually breathe on their own. So if they're not breathing, the CPAP is not going to breathe for them, it's not enough. Facial traumas, abnormalities, anything that precludes getting a good seal. That could even be as much as somebody that has a gigantic beard. Sometimes you get hard times getting good seals on those as well. Hypotension, so why? Because when you increase the pressure inside of the lungs, what happens is they put more pressure in the chest cavity itself. You're being cava is what brings all the blood back from your systemic circulation back to the heart. So what'll happen is it's a fairly low pressure system. So basically it's a squishy tube. You increase the pressure in the chest, you squish the tube a little bit more, and then they don't get quite as much blood returned to the heart, and then that lowers their blood pressure even more. So if you have somebody who is extremely hypotensive, then you need to really consider whether or not they actually need to have CPAP or not, or if you just need to address their blood pressure first before you put them on CPAP.
I would push back just a touch, because some patients who actually can get improved cardiac output and increase their blood pressure, it's rare, and I wouldn't say you should try it on everybody, but
Yeah.
if you have somebody who has too much preload and potentially too much afterload, if you can reduce the afterload in the aorta with your CPAP, then you can improve the cardiac output and actually improve blood pressure. And so in some patients where you have aortic regurg, so you're finding that already, and so you can push some of that out, and some other patients. Anybody where afterload reduction is a really important part, because you're going to reduce both the IVC pressure going in and push that back out and distribute that volume, and then on the aortic flow, you're going to be pushing it kind of out of the chest as well, distribute as well. So very few, but some patients you can actually improve their hemodynamics on CPAP or BiPAP.
Yeah, absolutely. And one of the things is if you don't know, and very often you're not going to always, I agree, but you're probably not going to. So,
Very rarely is
yeah.
they there, but
Yeah.
every once in a while you find one.
If they come to you and they're like, please reduce my afterload.
Yes.
Please reduce it, then absolutely.
Is that something we would probably see in the transport time, either one of those?
You could. Oh yeah, because the pressure is pretty much instantaneous. So you could see both. And so that's why what I've done before is I've just kind of tried it and then taken it and just watched it like at bedside.
Yeah.
But it wouldn't be something I would necessarily trial, because in most of these patients they're so ill anyway. That's probably not the first thing you would move to help with your blood pressure, especially if you have like a push dose epi or something in your truck. I would probably move more towards that.
It would actually surprise you how quickly these turn around, especially the heart failure patients that are in, fluid pulmonary edema that are just, fluid overload and short of air. That pressure peak it's amazing. You'll sit there for 20 minutes. By the end of transport, they're probably feeling much better. Then they get over, they're not on BiPAP immediately in the ED, and then they go back the other way. And so you can actually see them kind of worsen if they're not taken care of in the ED rather quickly, even though EMS made a lot of effort. So it's actually quite impressive how quickly that change in the afterload and that change in that positive expiratory pressure can cause a quick turnaround, especially if you have a 15-20 minute transport and they're on CPAP that entire transport.
I will say that this patient is a patient that I had in the ED, and so I started her on a nitro drip, put her on BiPAP, and within 20 minutes she was feeling a lot better and trying to convince me that she was fine to go home. She was not. She was not. She also later had a troponin of 53,000, so she was not okay to go home.
Don't you think they can be uncooperative too, because they're hypoxic?
Yeah.
Oh, yeah.
So a little bit of encephalopathy.
Versed.
Yeah. So
Is that the dose? Is that the correct dosing?
Yes.
The whoosh of
Yeah.
Versed?
Yes. That's somewhere between a pinch and a skosh.
Yes,
It's just a
let's go.
So, but yes, no, so like I said, sometimes they feel like they're drowning, they may be a little hypoxic, they're a little confused, and then all of a sudden you come and you try to, and they feel like
Yeah.
you're smothering. So sometimes a little bit of, sometimes Versed, Geparidol, anything that you can kind of, yeah, so whatever you need to try to kind of get them a little bit chilled out, they will comply with the mask, you can definitely turn them around. Yeah, like I said, it's one of those things, I don't know what your protocols are like, if you have to call before you medicate these patients, you have a standing order, so, which is.
Our medical director is only bed.
Perfect, I love that. I
wish I was
worked
a
at a very,
director like that.
I worked at a very, just do what you want, service for a really long time, and I really enjoyed that a lot. So, how to use this, so obviously we all know how to put a CPAP on, so I won't go over that, but you do need to continuously monitor these patients. As with pulse ox, with your end-tidal CO2, frequently reassessing these patients because they're either going to get better or they're going to continue to decompensate, and so you aware of what exactly is happening. Because sometimes you try CPAP, it doesn't work, you wind up eventually having to take their airway. So the way I like to do it is, again, it's a lot of pressure that you can run through these masks. So I like to start low and then just try to titrate up as much as I can based on the patient's work of breathing. So I just reassess them, start them off at 5, which is the lowest setting, and then just kind of go up and eventually just watch to make sure that the stats are getting better, that their work of breathing is improving, that maybe their mentation is getting a little better, and then once I get to that, that's kind of where I just leave them. I try to leave them on the lowest effective setting that I can. Because eventually, if you try to just keep going up and up and up, you're going to hinder their exhalation. You're going to make their hypoxia worse. You're basically going to be undoing all the good work that you did.
You have a recommended time to increase it, because I'm impatient.
So a couple minutes. Yeah. So again, like you're gonna see effects pretty quickly. So just like I would probably go give it a couple of minutes and then start off at 5, and if they don't improve, so they can go to 7.5.
Okay.
Give it another couple of minutes. You'll generally you'll see them here like that.
That's why I'm impatient.
Yeah.
So I just.
Yeah. When I started my journey of titrate pretty quickly, you can generally tell these patients will make changes very quickly.
Wow, way to go.
There we go. All right. You place patient on CPAP at 5 centimeters of water, rapidly up titrate within about a minute or two. To 10, her stats improved to 99, her respiratory rate slows to 18, and then she's transported to the ED without incident, which trusts to be paid May all the time. All right. Any questions or comments about that case? I know we talked about it a fair amount, but just anything else? Okay. All right, so case number 3. 22-year-old male is unconscious after an MVC with a significant mechanism. You have some bystanders that really want to help, so they grab this patient and they immediately pull him out, throw him on the sidewalk. They said that he did not have a seatbelt on. And now he's laying on his back on the sidewalk, again unconscious, and you see this on the windshield. So what is this concern?
Head injury.
Yeah, absolutely. So his head took a pretty good lick against that windshield. So what's this tell you about his potential injury? So he's unconscious, he's possibly got a brain injury. The other thing that we would worry about would be C-spine.
You're gonna transport this to Audubon, right?
The new Baptist Glen Mary works for me.
Oh, fair enough.
Yeah. Whole county would take a dog.
Hey, whoa, hey, yo, whoa.
Hey, my daughter worked at Alderman. They're Bullitt County's trauma center.
So I'm going to stay completely out of that. So
They can't defend themselves.
You
So
can.
your vitals, so he's hypotensive, 60/30, his heart rate is 58, respiration is 12, his SpO2 is 89% on remarried, his skin is warm and dry. So what are you worried about? Looking at this mechanism of injury with these vital signs.
Urogenic shock.
Urogenic shock, yeah. So absolutely. So these are very concerning. So this is one of the warm shocks. So we'll need to address that. So he begins to vomit. What steps do you want to do to clear this patient's airway?
Jaw thrust, suction.
Jaw thrust, suction. Absolutely. So you clear his airway using your jaw thrust suction, and no gag reflex. What next?
Rapidly making.
Yeah. So we'll talk about airway management and spinal cord injuries. It's a little different. So one of the very first things from one of the very first lectures that I heard in medical school from the good Dr. Hermy at DCOM, where we both went to school, or we all three went to school. C345, keep the diaphragm alive. So that is going to be the origin of the nerves that actually, the phrenic nerve that actually moves your diaphragm up and down. So basically what this means is if you can have these high thoracic and high cervical spine injuries that can cause severe respiratory compromise. So you can have paradoxical breathing due to diaphragmatic and accessory muscle dysfunction and paralysis. I've already had a couple of issues with the thing up here. I'm not going to try to play this video, but I'll try to show it later. So basically what it is diaphragmatic breathing. So you can have paradoxical breathing where, if you've ever seen anybody do belly breathing, so basically they're trying their best to force all of their other muscles to do the work of the diaphragm. So they'll be pulling in their, expanding their respiratory cage, and when they do, their diaphragm, instead of going down, it'll actually pull way up. So you'll just kind of see this weird paradoxical movement of their belly and their chest, and it just does not look right at all. Like I said, I'll try that video later. We've already frozen up several times. So, again, like we talked about earlier, on the CPAP portion, in awake alert patients that have some signs of respiratory compromise, you can consider CPAP for them. But if they need an advanced airway, the big thing is decreasing C-spine motion. This is not the time to try to intubate that patient and try multiple times to get a tube on them, because you definitely do not want to put them in a sniffing position. You do not want to throw their head back. So sometimes it's just better just to go ahead, throw an LMA in, and then transport the patient. So you do your aggressive suction in your jaw thrust, he remains hypoxic, and effective ventilations. You just go ahead, you throw an LMA in and transport the to U of L. So he's intubated in room 9 with a hyperambulated bleed under video laryngoscopy to minimize C-spine. So again, this is basic airway management, but I just wanted to kind of touch on this case just to say in C-spine, suspected C-spine injuries, that you definitely just want, the main thing is trying to decrease motion of the cervical spine and try your best to make not make that injury worse. Any questions or about that?
Can you comment on the role of end-tidal in these patients to kind of identify potential, if you have a spinal cord injury and your respiratory status is kind of getting worse en route to the ER, is end-tidal, would that be helpful to identify these people?
Yeah, so as you have your, are you talking about like as it?
Like their slow hypercapnia,
Yeah.
if their
Okay.
tidal
Oh, I
volumes
see what
are
you're
low,
saying. Yes,
and
so
we're not
you can use this. So again, the big thing is these patients, their respiratory muscles are not working as effectively, so gas exchange is getting worse. So as these patients continue to decompensate, you can start to see a slow hypercapnia. So you can watch their CO2 slowly start to rise up, and that could be a sign of impending respiratory failure that you would need to do an advanced airway. So yeah, so that's a good thing. Any other thoughts or
That
comments?
stair-step pattern.
yeah, kind of that slow. So that's like, you go into triage, like, oh yeah, they were just breathing like a minute ago. But that way you kind of find that beforehand, because your CO2 maybe starts going up, your tidal volumes are going down, so you may notice that.
Yeah, as they're, again, like I said, these patients, they will sometimes be breathing, just look like they're initially breathing just fine, but in reality it's very ineffective, and as they start to become more hypercapnic and more hypoxic, they'll start to tire out, and then, like I said, you'll start to see this slow hypercapnia, and they'll just kind of drift up in that stair-step pattern. And so it's just trying to head off a problem when it's still a little problem before it turns into a big one. All right, last case. So we have a 55-year-old male. He's choking at a restaurant. You arrive to find an obese male holding his throat and attempting to gasp for air. What do you do for him? Yeah, you can do back blows, you can do hind limb. So starting off with the basics, right? So we're starting off with the basics. We're trying that. Attempting the Heimlich maneuver. You're doing a great job at it, but it becomes unresponsive anyway. What now?
Resisting to the ground, resisting to their legs.
Okay. And then what else? You said so system to the ground, reposition his airway, and then what do you want to do? Start after that. Abdominal thrust, chest compressions, things like that, right? So chest compressions, airway doesn't clear, and then your partner says, "Hey, we can no longer feel a pulse. What do you want to do now?" Cry. Okay. All right. That's
CPR, let out some McGill's.
There you go. So this is I just wanted to include this. This is not what you do. This is from First Aid in 1943, How to Save Somebody from Choking. They did not have to include the tear, but it's kind of, they're really tied together. Really tied the picture together, so.
The prison tattoo.
The 1940s.
So we'll talk about airway foreign body. So they can very quickly devolve into a cane ventilated, cane oxygenate situation. They're a nightmare. So you can get a stepwise approach to clearing the obstruction. Never finger sweep these patients. So absolutely, McGill's. So going in and trying to remove it if you can see it. So you just basically take your laryngoscope, you try to look, you try to go in and find it. So it's great for solid pieces of food like steak, hot dogs, broccoli. It is not so good for soft foods like yogurt and bread. I was trying to think of something. I've got kids, there was yogurt sitting there. So.
Sauteed onions.
Sauteed onions, yeah. So at this point, you try your best to get it out, it doesn't work, so this is what you're looking like. So if you have a patient that you have tried to get the airway obstruction out, you tried multiple repositioning maneuvers, you can't ventilate them, they're not oxygenating, they've arrested. This is kind of your last ditch effort, so this is gonna be your cricothyrotomy. I took this out of the, I've got access to the Louisville Metro protocols, so this is what they use. They use the crikey. I'll be very honest, I've never used a crikey. The crike that I've done was the scalpel with my finger and a bougie. But this is what they, basically what they use. So basically all you're trying to do is you go down, you find below, get to the cricothyroid membrane, you make a vertical incision, you get the knife in to the airway, and then this gets inserted. So basically you have to get below the obstruction to be able to ventilate these patients. If you tried everything else, these patients are going to die unless you take their airway below the obstruction.
Fern Creek, you guys moved to this, right?
Control Crike, yeah.
Control Crike.
Okay.
Same stuff, I guess, different manufacturer.
Okay, so it is the same. It looks the same thing. Yeah, like I said, I had no idea what all the different services
It's
use.
got the double-sided
Right.
scalpel, and the trachea hook all built in like that.
Yeah.
And then the introducer and then the Shiley or the trach.
Okay, cool. Has anybody in here ever had to do one of these? Okay. Yeah, these are definitely an extremely, so these are what I like to call halo procedures. They're high acuity, low occurrence. So these are something that you may just want to every couple of months just mentally rehearse, like if I had this patient, what are the steps that I would do to actually go ahead? Because you definitely don't want to have to be thinking, oh shit, what do I do when you're looking like this, right? So just going through and just kind of rehearsing every now and then on some of these procedures that are in your purview to do, but you never get a chance to, maybe you've never done one before, maybe you do one a year. Then just kind of going back through and saying, hey, this is what I would do if this were my patient. They definitely say. All right, so you perform your crike, you're able to easily bag the patient soon after you get rocks, and then you transport to the hospital in stable-ish condition. So, any questions about that case or any of the other ones? So, here's my contact info. Anybody ever has any questions or anything like that, then these are some of the innovations I've done. No, I'm just so yeah, I just thought these were cool. So this was a transorbital intubation on somebody who had like multiple resections due to cancer, and they had to do some more surgery in his oropharynx, and so they said, here's a hole, we'll go in there. So this
He's got a perfect oral airway, why?
Why?
Doesn't matter.
Because oral airways don't get paper smokers, I guess. I don't know.
Dental procedures, right?
Huh?
The dental procedures.
Yeah.
Transorbital.
Yeah, it said
He was
the-
having an
the-
implant put in.
The paper said a novel approach to airways.
A novel.
Yeah, and I was like,
A novel.
He was a buddy.
That, I have no idea what happened there. That's not the location for a crike or normal airway, so I'm not sure that's gonna make their mind. This.
Maybe a bump in the road.
This is what happened when you try to crack somebody going down the road.
And they press the
Boom,
trigger
oh,
bar.
okay. This was a pretty interesting case from several years ago. I don't know where it was, but somebody tried to place an NG tube in somebody who had a basilar skull fracture. They went directly down the spinal canal and then initiated feeds through that tube. And that patient that is just another way to kind of hammer home, if you have significant facial trauma, if you have concerns for a basal or skull fracture, please do not put anything in your nose. So, because these things, they do happen. But anyway, all right, so does anybody have any questions for me? All right, thank you.
You ready? Awesome.
So how I'm gonna follow that?
Yeah. No pressure. Let's get
No pressure.
That's why. Yeah, that's one else like. I was freezing up, and I was also like kind of
Say no. If you don't mind, this is a clip, or I can get a magnet if you prefer.
No, it's fine. Where do you want me to clip it? Just,
Sure, fine, that's fine.
all right. Hi, good morning. My name's Amy Ball. I am the clinical education coordinator for Norton Transport. So I take care of all of the education for the adult side and for the pediatric side. So I got roped into that position because I was an adult nurse in the first third of my career, and then a pediatric nurse the second third, and then this last third. I am old enough to do thirds at this point. I have been a transport nurse, so I said, I cannot follow Luke. I am not funny, man. I don't know how I'm going to do that. One. Two, I had no clue there would be so many physicians in the room, so, you know, pardon me. So I'm going to talk about pediatric and neonatal airways. They are very different, unlike what some people feel and think, and we treat them differently. And so, given that since 2008, pediatric and neonatal airways is what I've taken care of, I got elected to be the person to give the talk. I have no disclosures except for I work for Norton Healthcare.
So you're funny.
We're just going to talk about airway anatomy. Bag mask ventilation. Bag mask ventilation is all about it. If you can bag a baby, then you're going to get there. And as you know, cardiac arrest in pediatric patients typically stem from the airway, and so bagging that baby is going to be your best option. And then we'll talk a little bit about assessment. Hal is featured, so if you all do not know, we have a high fidelity mannequin named Hal. We travel with him several places. You've probably been to some simulations with Hal and or participated in them. And so Hal will be featured throughout the slideshow, so as will our simulation team and my partners. So if you all don't know, I did Donna Callahan Banks and Lauren Johnson in the back, along with Dr. Karen Norman and Dr. Beth Sperling, are our simulation team and our outreach team. And so they go throughout the state of Kentucky and go to EMS stations across the state of Kentucky as well, and provide outreach and simulation. So they will be featured as well. So the neonatal airway, as everyone knows, it is very different. They're born with very narrow nares. They have a very large tongue. If you've ever tried to intubate an airway or a neonatal airway, you know that the tongue gets in the way and you have to wrestle with it. They have a very high glottis. Their vocal cords are slanted and they have a very narrow cricoid ring. On top of that, their head is gigantic. So you've got to move the head out of the way, right? So how do we reposition them? So what makes that airway unique? Well, they're obligate nose breathers. So when they're born, the very first thing we want to do is clear those nares out, right? We want to get whatever secretions or things they're born into this world with, be it meconium, be it vernix, be it amniotic fluid. We want to get that out of the airway. So we've got to clear the airway. They're less rigid and more flexible. And then their vocal cord color actually depends on their gestational age. So the younger they are, the harder it is to see the vocal cords. They're pink and they don't look like what you're used to seeing on adult patients. And so adult patients, you know, they're white, they're very visible. Neonates are typically anterior, so you need to give a little, positioning is everything. And a lot of times they require a little bit of cricoid pressure because their airway is so anterior. And so that's why when you're looking for vocal cords, you may not see them. A little tip that we do, we actually place an NG tube a lot of times prior to intubation on a neonate, especially the smaller ones, so that we can help distinguish. Just helps give a little marker. And then the pediatric airway, again, it changes as they get older. However, it's still, so I was informed yesterday, I have not seen the study yet, that the airway talks about how it's cone-shaped, but there's more and more studies coming out talking about how it may not be as cone-shaped as what we thought, and it may be more like the adult airway. They're doing MRI studies now to kind of look at it and see what does that airway actually look like. So this may actually be debunked, so I'm going to skip over it and pretend like it's not there. So,
Use more cup tubes
yeah,
in everything.
yeah.
That has gone the way of the dinosaur. We put cup tubes in anybody who's gone home and come back
Mm-hmm.
in the pediatric world.
So neonates, we used uncuffed ET tubes, and in all pediatric patients, we use cuff tubes,
Even if they're 2 days old.
even if they're 2 days old. So always a cuff tube. And when we go out and do our education, we make sure to inform people. We carry down to a size 3 cuffed tube on all of our trucks. So that's something that we try to do a lot of education on. And even the premature babies that have gone home and we've corrected them to 36 weeks and they've gone home for a day and a half and then mom brings them back in if they need an airway, we're putting a cuffed ET tube in them.
What about I know there's always been questions about the pressure, and I always saw respiratory therapy going around and checking the pressure of those.
Yeah, so
What's
we
the-
actually,
I'm just
so
curious.
less than 25 millimeters mercury is what you want in the cuff. So we actually have a manometer where we measure those. If our team shows up, we're measuring cuff pressures
Is
because
it
we want
typically within, or is it usually higher? Or?
it's usually higher. So people
Okay.
like to have it around 40, 45.
To be fair, in that population too, they're normally waiting for us to intubate.
Yes, they also are
You know,
waiting for
your
them.
older pediatric kids,
Sure.
a lot of physicians are more comfortable trying to intubate those kids.
Fair.
The small ones, they're normally waiting for
They
us.
kinda
and
wait.
We're checking.
They
the
will,
pressure.
yes, they will bag a baby until the JFK team arrives, always.
How long have you been doing that? An hour?
Yeah.
They've done some studies that your fingers pinching on the little balloon, you can say, yeah, that feels about right.
Oh, yeah.
It's not.
Not even
as
close.
Yeah.
low as you think it might be.
Interesting.
I have a question, and maybe there's not an answer, but if you have to intubate one of these kids in the field, is there any way that you need to like estimate pressure, or do you just kind of go when you inflate the balloon?
Of the pilot balloon,
Yeah.
if you can have it all, sometimes the cuff is enough to be enough external diameter to do its job even completely deflated.
Mhm.
So you can just put a little, and as long as you're getting chest rise the least amount, it could be all the way to flat.
Okay.
But if you just put a little amount, but if that balloon is hard as a brick, it is
That's too much.
Okay.
If you have a kid, back to your first cases that are ancient, but for us, but where they have florid pulmonary edema, we want it to be less than 25, but if it takes more than 25 centimeters to get gas exchange, like if you're having to bag with higher pressures, then you won't achieve it. You know, you'll bleed too much.
So
Does that make
basically,
sense?
it'd be intubate them, try to see if you can get chest rise, and then just kind of incremental
Yeah, you
increase
have
in
to
the balloon.
CC, have to CC.
Okay.
Yeah.
All right. Yeah, because most
Is that fair,
services.
Bill?
are
We
not gonna
never
have
check.
pressure.
Yeah.
You have to,
Yeah.
you have to check or you can actually give them some like stenosis or ischemia, so.
So half a cc at a time is basically the kind of the rule of thumb. And we do, so on transport, we carry something called a cuff fill syringe. And so they're relatively inexpensive. And I can show you how it works, although I'm walking away from the camera.
That's okay.
But,
Yeah.
so you press the little yellow button and then you can actually just kind of fill.
Kind of
And
feel
it,
like it gives
and
a
it
pressure
gives you
monitor.
a pressure. So we carry these. That's what we use to, and you can pass it around. That's what we use to check pressures on all of our patients' cuffs. So again, pediatric patients, especially toddlers, have extremely large heads. So positioning, positioning, positioning. We want to make sure we get that head kind of moved and out of the way. We also have to remember that they have loosely attached mucous membranes. So when you're intubating them or trying to get some kind of secondary airway, an LMA, something along those lines, supraglottic airway, then you want to make sure that you're taking that into consideration. Again, their tongues are huge, so you're going to have to wrestle that. So how do we get that out of the way? A lot of times, especially on our neonatal population, we use Miller blades, not Mac blades. They work better. And because again, their airway is also anterior, so it works better. So always think Miller, the smaller the baby, and then Mac, the bigger the kid. So we also have to keep in mind that you stole my thunder with the McGills, man. So their airways are smaller and become easily obstructed. The worst coding patient I have ever seen was string cheese. I hate string cheese. I coded that patient over at Clark County for 45 minutes, and then we brought them back to Children's because we finally got the string cheese out. I hate string cheese. Would not buy it for my child when she was small. Hot dogs, grapes, so button batteries. So button batteries are the worst. That is a surgical emergency. It will erode the airway. So, and it's not just toddlers who will eat button batteries, it's also your autistic patients. We actually just transported an autistic patient who had ingested 4 button batteries, and he was 16. So you have to, when they say, oh, I think they swallowed a battery, we really need to be thinking about what kind of battery was it? How long ago do we think that they swallowed it? Because if it's in your esophagus even, it will erode and then go through to the trachea. So then they end up with something called a TE fistula, and it is truly a surgical emergency. So that's something that we always have to consider. What if they swallowed? I was on orientation with Donna, and we flew to somewhere very far away. I won't say because Lauren is on call later the day. So we flew somewhere very far away. We were in our fixed wing, and Vicki Montgomery, who is the medical director for the pediatric ICU and had been for a very long time, was our medical control physician. And we were intubated. We extubated in the fixed wing and had to bag the patient because we turned with the patient needed sedation. I'm trying to get sedation. Donna turns to ask me for sedation, and the tube just came out because we were bagging. But what we did not know was that the patient has swallowed a piece of plastic off of like a packaging. And so when we actually extubated them, we actually pulled the piece of plastic up far enough that when we got into the PICU, they were able to take McGill forceps and pull it out. Vicki, who drops her glasses down on the end of her nose and says, the only reason I am not upset with you right now for the extubation is because you removed the piece of plastic. And I was like, thank you. So It happens. They swallow things. Barbie shoes are the worst. Hate those too. So small, inanimate objects. Their airways are flexible and susceptible to collapse. And then their airways are also very reactive, and so they can have laryngospasm and bronchospasm. Any questions, comments? All right, so bag mask valve. The important concepts to remember in a pediatric and a neonatal patient. Always choose the correct equipment. Size matters. Despite what they tell you, size matters. So, sorry, see, I'm trying to be funny, it just isn't working. Okay. So, mask size matters, ambu bag size matters, size matters. Positioning, positioning, positioning. Again, you've got to get their head out of the way, and you've got to get their tongue out of the way, and you've got to get their airway opened up. And then your mask seal and technique when you're actually bagging that patient, and then ventilation. So you're going to bag a neonatal patient different than you're going to bag a 2-year-old, different than you're going to bag your teenager. So when you're looking at the correct mask size, you've got to know how to measure. And so you don't want to be smushing down on the airway either. What you want to be able to do is encompass that entire airway. So you're going to measure from the glabella to the chin. So always pick the right mask size. Your neonatal patient and your pediatric patient, there's actually a weight range on your ambu bags. So make sure you're picking the correct, just because they're, I don't know, 6 months old, they may only weigh 3 kilos because they were a premature baby. So, which is probably a horrible example. But what I'm saying is make sure you take into account your actual patient's size when you're picking your ambu bag size. And then we like to put all of our patients in what we call the sniffing position. I'm sure everybody's heard of that. So we want to make sure that we're extending the neck with the help of a shoulder roll. Shoulder rolls are amazing, especially in that neonatal population. You're going to help move that head out of the way, and you're not going to hurt them. They're made to be bendable and flexible. So keep that in mind. Think about how they come into the world. They have to bend and flex to get out, right? And so their bones aren't calcified yet, and they're going to be able to bend and flex to get that head out of the way. Now, if you hyperextend their head too much, you're going to flatten out your airway and you're not going to see it. So you've got to get them kind of just right, but you want to kind of sniffing position, get them just straight. The EC hold and the jaw thrust is super important in the pediatric and neonatal person. You want to be able to pull their jaw up to you. You don't want to smash the ambu bag into them. If you smash the ambu bag into their face to get a good seal, you're going to occlude their airway. And then that big giant tongue is also going to create an obstruction. So what you want to do is pull their jaw up to you and then have that EC hold so that you can open up their airway and then get their tongue out of the way. And then when you talk about ventilation, for any neonatal baby, so baby just born, you want to bag them, if you're doing CPR, 1, 2, 3, breathe. And then you kind of want to keep that same count, even if you're just rescue breathing for them. So you count, 1, 2, 3, breathe. 1, 2, 3, breathe. Their respiratory rate is a lot faster than what you're used to on an adult patient. Adults, we bag for a rate of 12 to 20, right? On a neonatal patient, we want to hit that 30 mark easy. So you want to breathe faster. You want to provide consistent breaths. So if you have a manometer on your ambu bag, that's the best option. We want to keep that pressure less than 20. We also want to bag for chest rise. That's the most important piece. Do you have chest rise? Because if you don't, it could be positioning. We might need to get them in a better sniffing position. It could be are you smashing on their face rather than lifting the jaw to you? On your pediatric patients, again, they need a faster rate. So their rate of 20 to 30 is kind of where you need to be the smaller they are. But as you get up to the teenage years, you're going to bag them more like an adult. So again, think about the normal respiratory rate when you're looking at how old is the baby, how old is the toddler, how old is this school-age child. And it may be that you need to just bag them a little bit faster, but try and keep that same consistent pressure. So, key takeaways. Positioning is everything. Shoulder roll, shoulder roll, shoulder roll. I love a good shoulder roll. We carry washcloths just so that we can get a good shoulder roll on those neonatal patients. Love a good shoulder roll. Cricoid pressure might be something that's necessary. And then your correct size equipment is the biggest thing that matters. So then when you talk about airway, you have to also think about upper airway obstructions and lower airway obstructions. So when you're looking at the upper airway obstruction, what is causing the upper airway obstruction? And so could it be an infection? Could it be a foreign body? Could it be a mass? Hypotonia. We have a lot of CP patients out in our population, out in Louisville. And so what does their airway look like at baseline? So do they have some hypotonia? Traumas and burns, and then the treatment or the cause determines the treatment. So I know for our teams, we carry things like racemic epi, we carry Heliox, and those are typical hospital treatments. But you all have things like what? What do you carry that could treat an upper airway obstruction? You all have racemic epi. So croup. So what does that sound like? It's that seal-like barky cough, and they have stridor, right? So if you hear that, if you walk into a house and you hear that, you're like, oh, I'm gonna make some racemic epi today. It's always at midnight. Or mom calls and she said, well, it's December, and she said, well, we walked outside and it got better. Well, they walked outside and got better because it's cold outside. But when they walk back in the house and it's 72 degrees inside and dad's sitting on the couch smoking, and then now the baby's got a seal-like barky cough again, you're like, well, this is what happened. So there are ways to treat upper airway obstructions, but what you do have to think about is how severe is this upper airway obstruction. So mild upper airway obstruction, you don't really hear any stridor at rest. They have minimal retractions, and their O2 sats are greater than 94% on room air. If they have moderate upper airway obstruction, they have stridor at rest, retractions, and decreased air entry. And then severe upper airway obstruction, they have stridor at rest, drooling, grunting, cyanosis, altered mental status, significant retractions, it goes on. And so these are patients that if it's epiglottitis, if it's croup, it may be that it behooves you to, if you need an advanced airway prior to getting to the hospital, that you use some sort of supraglottic airway rather than trying to intubate with an ET tube. Why would you think that? Yeah, 100%. You're going to irritate that airway, and you're just going to cause it to close off. Epiglottitis is the worst. We've transported 2 in the past 6 months, and we actually used an i-gel on one, and the other we just opted to bag because they're surgical emergencies, and so we want to get to the hospital where we can actually take them to the OR and do it in a controlled environment. Lower airway obstruction, so again, what's causing it? Asthma, foreign bodies, mass, bronchiolitis, and inhaled chemicals or burns. So you all have albuterol. From our perspective, we give a lot more albuterol. We throw the albuterol at them. And so albuterol, albuterol, albuterol. Just when you think you've given enough, you need to give some more. So that's how you're going to open up those lower airways. We start with 5 milligrams. I know state protocols say 2.5. So, but 5 milligrams is where we start at the pediatric hospital and on transport. Atrovent, steroids, magnesium, terbutaline. IM-epi is my favorite. I love a good dose of IM-epi for asthma patients. There's something about it, it's almost like an instantaneous fix. And the only reason I feel that way is because my very first trip over 10 years ago, after I came off of orientation, I walked into Audubon, and the mom walks out the door and lays a limp baby in my arms and says, "Please help me." And I said, "Okay." I turned to my partner, who was Ryan Thompson, and I went, "Please help me." He was like, "We got this." Like, okay. We did all the things. We started an IV, we gave a mag bolus, we did albuterol, we got back, and who did I get to debrief with because she was my med control? Of course, my med director, Karen Orman. So I walked into the physician call room, and she said, "The one thing you could have considered was IM-epi." And I was like, man, I didn't even think of it, because in the moment I was panicking because mom hands me a limp baby. So from that moment on, my go-to drug has been IM-epi, and it works like a charm. I no longer say you'll feel better after this, you'll be able to breathe, because it makes you feel like trash. Your heart rate's fast, you don't feel good, but you can breathe. But IM-epi, love a good dose. Just some lower airway obstruction takeaways, just for your knowledge. Severe bronchiolitis risk factors, if they're less than 12 weeks, prematurity, underlying cardiopulmonary disease, and immunodeficiency, that makes that risk of bronchiolitis even higher. And then severe risk factors for asthma, so severe or fatal asthma, poor compliance. We all know that there are a million kids out there who go, "I just forgot to go get my refill," or "I haven't been taking it." My daughter is one of them. I want to beat her right now. So she's like, "I just haven't been getting my allergy shots." What? Yeah. So history of intubation, or if they've been hospitalized or been to the ED in the last year, food allergies, and then if they have PCO2s greater than 50. Bronchiolitis may respond to albuterol if the patient's over a year old and RSV negative, which of course you're not going to know if they're RSV negative, but it doesn't hurt to give them an albuterol if they're over a year in age and say, "Hey, does this work?" We've seen a good response, especially last RSV season. We saw a lot of kids respond to albuterol. And then you can always consider, we use heated high flow on our transport team. It is a godsend and a savior of intubation, but BiPAP or CPAP for moderate distress. And then, as you all are aware of the pediatric assessment triangle, but we're only going to talk about airway and appearance. And so just a little mnemonic to kind of help you think about where you are and what you're looking for. So tone, instructiveness, consolability, look, and speech. So tone, are they floppy? Are they purposeful? What do they look like? If they're old enough to follow instructions, if they're old enough to kind of say, okay, yes, if they're grabbing for things, if you're trying to take their pacifier away and they're trying to grab at it. Consolability, that baby who is crying nonstop, there is something wrong with them. Whether they're 2 days old or they're 6 months old. And then what do they actually look like? So do they look like a normal newborn baby? Do they look like they're breathing okay? Or do you see suprasternal retractions and you see this little divot right here just sinking in every time they take a breath? Are they head bobbing? Are they nasal flaring? Nasal flaring is not normal. And then speech. So our 10-year-old asthmatic, are they speaking in complete sentences, or are they taking a break between each word? So you have to always look at all the pieces and parts. Any questions, comments? concerns.
How did you on that on kids? Use those or no?
So,
We don't carry them.
no,
We typically in our first hour long behavioral treatment we give, we would.
at check vent.
Okay. That's all you measure on? You got it?
Absolutely, 100%. We love Solumedrol.
I always say, if this is a kid that thinks he's gonna go home, don't give him Solumedrol, because we're gonna give him Daprodrone.
Mhm.
That way it saves him from the, steroids are great, but it takes about 6 hours for them to really kind of kick in. And the evidence shows that you might improve their hospital stay, at least the stay, but it doesn't necessarily mean, the end. And the other thing I just wanna comment on, and maybe, I don't know, Brian, or Luke, if you talked about this, is you're going to intubate, and there's obviously reasons to intubate a child that's not coding. One of my concerns is you guys are not giving the tools, the medications to do the intubation. So if you're going to intubate, a 4-month-old that's respiratory distress from bronchiolitis, let's say, what medication are you going to use? Intubate.
The Metro protocol is just etomidate, rock, I believe, and there's no additional.
You can't give a
There's-
paralytic.
oh, I'm sorry.
You can't give a paralytic to, that's, the protocol is.
Sorry
you
for
can't give a
adults, sorry, I
paralytic,
apologize. I'm
right?
not thinking of kids,
Yeah, and
I'll
that's, and that's the problem, because you're going to vagal them, because you're, and I think sometimes cause more harm, because you're not given the proper tools to actually intubate them. And so that is always my biggest concern, is going to intubate a child without the proper medications.
So we have some pediatric like RSI as well.
There is none. And so I'm a firm believer, if we're gonna allow you guys to intubate, which you should be able to, we should give you all the tools to intubate. And I think that's the conundrum that you guys face. Sometimes I would just say to an LMA, because it might be easier, but then, and if it's gonna fight an LMA too. So, you guys are kind of stuck.
What about the terbutaline? That's something that I've never used personally, the terbutaline. Is that something that outside of pediatrics, is that something you guys are seeing more and more, or is it just more pediatric, I guess?
It's an old drug. We use it on our really sick asthmas.
'Cause I know it's in England, they use it a lot still, I think. I think it's still pretty common there. And I know Australia, I think they use it still. So it's one of those things where we don't do it, so I'm always curious.
Is your question outside of a hospital?
Well, yes,
or in a hospital?
do you see it as, is the evidence only in pediatrics, I guess, to your all's knowledge? And is it something you see good improvement with?
I'm sorry, I don't know the adult literature on
Fair.
terbutaline, but we use it as, I don't know, fourth line maybe. We use
Okay.
albuterol, an anticholinergic, magnesium, and then either terbutaline or aminophylline.
Okay.
And so, the terbutaline can be given a lot of different routes. You can give it IV, you can give it nebulized. And so we kind of think of it like IV albuterol.
Okay.
So we'll have people on terbutaline infusions once they make it to the 50. And, it can work just as effectively as a bronchodilator as albuterol.
Cool.
So
Thank
if
you.
we're on terbutaline, we'll back down our albuterol dose so that we don't get as much tachycardia and tremor. It works pretty well, actually.
Cool.
Yeah.
Thank you very much.
If they do have a neonate that they have to intubate in the field for whatever reason, what are y'all's thoughts on, or what are your thoughts on pretreatment with atropine?
That is a very interesting question, Luke, because of what PALS came out about in the last iteration. The new PALS is supposed to come out from AHA at the end of this month, and I doubt it will change, but it says atropine is optional in the infant period, and I humbly disagree with that because there are some kids whose vagal tone remains high outside of the neonatal period, and so even if their heart rate's 170, 180, if I'm gonna put a blade in a small infant's mouth, it is amazing how fast their heart rate can become 50 with that. And so I don't let sinus tachycardia keep me from an atropine dose, because I'm trying to protect them from the bradycardia
You said the name.
Yeah, I said it. But
We let us know that we don't like that.
we don't say the places that we could go. But it was a MRSA mass that was growing in front of our eyes. And so the airway was completely shifted, and the only way we could get the patient intubated was we had to literally cricoid pressure wasn't even a thing. Like, you had to pull the airway straight, give a little cricoid pressure, but every time we did, the heart rate would drop to 40. So essentially, we gave atropine, but even when we did that, I basically said, please do not look at the monitor and let me just do this, and I had to intubate that way, because we had to get an airway.
Yeah.
So, even in spite of atropine, sometimes you still will see horrible bradycardia.
I agree with Karen, I use it all the time with
Yeah.
ED.
Yeah, I just wanted to mention it because it's definitely not something, if you're intubating in the back of a truck, I've intubated a couple of kids, it's not something that I routinely do in adults and I did not think about, and so I've had a patient breathing down that little baby that was tubing in the back of a truck breathing down, and it scared the crap out of me. So just remembering that that's part of that little thing was worth mentioning.
It sounds like from Amy's description, she was basically doing a carotid massage. Picturing just like pushing, on the mask.
It was quite
I think
interesting.
probably the carotid massage won over the
Yes.
atropine.
It was, of course, Ryan Thompson again, and he's literally, it's two of us intubating because he is, thank goodness he's taller than me, but he is behind me, like positioning the airway so I can intubate. It was ridiculous, but we did it. I just want to point out that the nurse intubated, not the respiratory therapist. We do talk about
All right, thank you.
Any other questions for Amy? Thank you so much, Amy. Our last lecture, you got it, for the morning, then we'll head into sim session. And I'm excited because I think everybody will be able to experience the sim sessions, even the people who are running the sim sessions. So I'm excited to see that. But first, we're going to have Mac as our last lecture of the morning.
All right, good morning. I think I've met a good amount of you. I'm Matt Lyons. I am a third-year resident in emergency medicine at U of L. I also got my humble start with Metro way back when. I've been involved with EMS since then, so it's exciting to be coming back full circle again. I'm going to talk about some pre-oxygenation pitfalls today that I've seen both in the ED as well as in EMS. Kind of the things that I want us to do is to be able to describe some of the physiology behind pre-oxygenation, to recognize these common pitfalls, and also have some strategies on how to address them when we see them. I hate being called on to answer questions, but I hate calling on people to answer questions even more. So the way for me to make this interactive is if you can take out your cell phone, scan this QR code, there's going to be some questions along the way. I'll give you just a second. If you see a question pop up, don't answer it yet. It may not be the right question.
What if I already answered?
Then that's all right. You're ahead of the game.
Asking for my social security number.
All right.
Forget your bank account information.
Let's see if this is going to work. Are you all seeing this on your phone, this question? Awesome. Go ahead and answer it. It's just a little bit of a warm-up. What is... No. Oh, man.
What is one thing you're going to do differently next time?
No. Let's try... Here we go.
Always double dip.
100%.
All right, that's okay. We're just gonna have to do what I hate, and you all are just gonna have to answer the questions out loud. So we'll just start here. We'll start with the definition. What is pre-oxygenation? Something super simple, but something that a lot of us don't really think about. Delivering high concentration oxygen and doing it in a way to maximize the oxygen reserves within the lungs. So it's essentially just getting as much oxygen into the lungs as we possibly can. Super simple. But what does this actually do for us? It's all about, what do we have here? Medics? Do we have any techs? All right. So it's all about making our safe apnea time as long as we possibly can. Safe apnea time is the amount of time between when the patient stops breathing, whether it's because you pushed meds or they just got so sick they stopped breathing on their own, and when they reach a point of critical desaturation. So have you all seen before when, we'll use intubation as an example, when you're intubating a patient and you see their O2 sats, you start at 100 and you kind of slowly trickle down, but once you hit that 88 to 90%, it seems like they just drop like crazy. Yeah, it's actually a physiologic response. It's a real thing. It's not just you freaking out that it's dropping fast all of a sudden. So the safe apnea time is keeping them above that 88 or 90% before they fall off the cliff. Now, if we were to take somebody in here who is relatively healthy, and I decide that I'm going to give Paula a paralytic, and I'm going to make her stop breathing, we have about 3 minutes before she goes from 100% to 88%. It's a lot more time than I thought it would be. But if we were to pre-oxygenate her first and then give her a paralytic, we can almost double that. We can get up to 5 to 8 minutes just by maximizing the amount of oxygen in the lungs. Now, the patients that we're going to be intubating are hopefully not like Paula. Hopefully they actually need an intubation. So we're not going to have 3 minutes, but we may have 1 minute, and we can maybe turn that 1 minute into 2 minutes. And these are all cases where time is really important, and every second, every minute counts. I'm going to put a couple patient cases in here just to kind of help us illustrate some of these pitfalls. So the first one, we have a 38-year-old male. He's a GCS of 4 after a motor vehicle collision. You decide you're going to intubate. You put on a non-rebreather for 30 seconds. You have the patient lying flat. You attempt to put the tube in. You pull the non-rebreather off, and the patient goes from 97% to 75% in 15 seconds. This is a classic failure of pre-oxygenation. This patient was not pre-oxygenated well at all. Let's go over a couple things we could have done better. Oh man, I'm going to give it away. How long do you think we need to pre-oxygenate a patient? How long do you all pre-oxygenate a patient? Or do you even have a set time? Do you just throw it on? And
We get 1 minute needy.
1 minute?
I don't think I've ever timed myself.
Yeah. So there's...
Looks good.
Getting the equipment ready. You start bagging the better.
There's actually some studies out that show it's not just when you hit that 100%. That's when your SpO2 is 100%. But you actually haven't maximized your oxygen yet. You should really be going for about 3 minutes or 8 full volume breaths. That's not like 8 quick bags, but it's full inspiration, full expiration using their full lung volumes. And again, that's to make sure we maximize all of the oxygen. We'll talk about how that works. Really, the area in the lung that we're trying to work in when we're pre-oxygenating the patients and why it takes so long is what we call the functional residual capacity. Have you all seen this diagram before? This is like going way back to physiology. So, if we look, these are lung volumes over here on the side, time on the x-axis. And this is the patient just breathing normally. They breathe in, the lung volume goes up. They breathe out, the lung volume goes down. These are just normal breaths. But then we hit this really big spike over here. This is you telling the patient to take in the deepest breath they can possibly take in. And we're using so much more lung than just in normal breathing. Then we tell them breathe all the way out until you can't breathe out anymore. And that's this big valley that we're getting here. The difference between you when you just breathe out right now and when I ask you to push out as much air as possible, this blue line here, is your functional residual capacity. It's just that extra amount of air, and this is where we can really maximize our oxygen in these patients and help us buy time. And the way that this works, if you want to get a little bit in the weeds with this, is all about what we call denitrogenation. So when you're breathing room air, only about 20% of it is oxygen. About 80% is nitrogen, and you have less than 1% that's kind of some other stuff that we don't really care about. But what if we were able to take that 80% nitrogen and replace it all with oxygen? That's what good pre-oxygenation is, and that's also why it takes 3 minutes or 8 large breaths to flush out all of that nitrogen. And it takes your lung volumes, this was another study that I saw, it can take the amount of oxygen in your lungs in one study from 450 to 3,000. You're tremendously increasing the amount of oxygen and buying yourself a lot of time with this. So it's really simple. We forget about it a lot. It's usually a last-minute thought to just, oh, let's bag them real quick before I put in the tube. But this should really be your first step when you're starting to intubate a patient, or even thinking about intubating. All right, I'll ask you all, what are some ways that you think we can maximize the amount of oxygen in the lungs? PEEP. All right, good. What's any more? Positioning, yeah. Did you read my PowerPoint? You all are getting my 3 options perfectly. Positioning. In this case, and what admittedly I was doing a lot in the beginning is I'm pre-oxygenating patients, and I said, well, they're going to have to lie flat to be intubated anyway. Just go ahead and lie them flat while we pre-oxygenate them. But if you think about it, you're kind of working against yourself. When you lay a patient flat, you have all of this tissue on your chest, all of the bones that's pushing down into the lungs and not letting them fully expand. I think about this kind of like our COPD patient. What does this really sick COPD breather do to themselves? Yeah, they tripod. They sit upright, they take all of that pressure off their chest, let gravity pull their diaphragm down. So why don't we do that with our patients? Don't tripod them, they'll probably collapse forward. But you can put them up about 20 to 30 degrees and let gravity help you with your pre-oxygenation too. PEEP is something that I felt like was always this really foreign concept, and it took forever for me to get a grasp on it. It was an embarrassing amount of time to get a grasp on it. But
okay, I knew your physiology professor.
Thank you. Yeah, subpar physiology. But what it is, it's the positive end expiratory pressure. It's the amount of pressure that's left in the lung at the end of a breath. And this is important to have. I think about this like blowing up a balloon. So when you take a balloon fresh out of the pack, you stretch it. I don't know if that actually helps or not if you stretch it, but everybody stretches it. You put the first breath in, and you get the balloon blown up a little bit, and then you put the second breath in. Which one's easy? Which one's harder to do? Is it harder to do the first breath or the second breath? The first one. You have to overcome all of the tension and the forces within the balloon in that first breath. And then that second breath is a lot easier. And that's exactly what this is showing here. Our lungs work the same way. If you're starting out from a collapsed lung, you're starting all the way on the left, you have to get that giant breath in just to pop it open a little bit, and then get a second breath to actually get a good amount of volume. And this is what some of our patients are working with. And if you can only pop the lung open half the amount, you're only working with half the amount of oxygen. So this is the cycle that a lot of our patients are stuck in. But what if we add PEEP? We increase the amount of pressure that's there when they exhale all the way. We can essentially move them over. So we're now starting as if that first breath is already there, and you're just giving that second breath every time. Does that make sense? How can we do it? Does anybody have one of these? You recognize these? No. Yeah? What is it?
PEEP valve.
PEEP valve. Yeah. I think we're starting to see them on more trucks. I know Metro didn't have them when I was there. But this is a valve that you can put at the end of your BVM, and when you deliver those breaths, caveat, you have to have a really good seal on it. It keeps that pressure down into the lungs, and you can get a little bit of PEEP when you're bagging the patient. And this is a great rescue for if your patient's not oxygenating well, you can't get them quite up to that 100%, add a little bit of PEEP. See if you can open those lungs up a little bit more, and you'll probably get better oxygenation too. What's another device that you all have on your truck that can give you PEEP? CPAP. Yeah, that's exactly how CPAP works. So, in this case, we had 3 big pitfalls. Number 1, inadequate time. I just think of it, when you're ready to intubate, start with pre-oxygenation before you even set up any of your intubation stuff. This is a great thing for the tech. Have them start bagging the patient, have them throw on the non-rebreather before you start doing anything else. Poor positioning, put your patient 20 to 30 degrees heads up, and then make sure you pick your correct O2 source too. Non-rebreather, turn it all the way up, or you can use a bag valve mask, and if you have a PEEP valve, add your PEEP valve. Any questions about these?
What about increasing their tidal volume? Does that help or no?
Yeah, you definitely can. You definitely can. Now, of course, there's an upper limit to all of this too, right? You don't want to add too much and blow their lungs, but yeah. All right, second case. You have a 65-year-old female. She has a history of COPD. She's on 4 liters nasal cannula normally. When you get there, she's setting 82% on a non-rebreather. She's in obvious distress. You try to pre-oxygenate her, but she's not really tolerating it well. You can't get her SpO2 above 90%. Let's say that you have medications that you can use to assist your intubation. What do you want to do? I'll give you the option of you can either go ahead and push the meds and just intubate really quickly. You can try CPAP. You can say, I'm just going to leave her on the non-rebreather until eventually she gets up to 100%, or you're just not going to intubate her. You're done.
Is she awake?
Yeah, she's awake.
Put her on the CPAP.
Yeah. The big wrong answer here is pushing the medication and going for it, right? This is a super poorly pre-oxygenated patient. This one is so close to that critical desaturation point already that as soon as you push those medications or as soon as you stop her breathing, I promise she's going to tank in probably about 15 seconds, just like that first case did. So reach for your other things if you have them. Try CPAP. Put her on that. Even if you can't leave her on it long term, put her on it for 5 minutes while you're waiting to intubate her. Give her the PEEP if you don't have the PEEP valve. Get the oxygen up all the way, and then go for the intubation. And this comes back to thinking about what is the risk of your patient, because this is really going to change your approach. These are who I really think of as the high-risk patients: obese patients, pregnant patients, kids, and the COPDer like we had who's already on 4 liters of oxygen normally. And it really comes back to this that we looked at the beginning. All of these patients, if you ask them to breathe out all the way, they have even less room to breathe out than we normally do. The obese patients have their beer belly pushing up on their diaphragm, and they can't expand as much. The pregnant patients have a baby doing the same thing. Our kids have smaller lungs. And then our chronic lung disease patients that we see all the time, their lungs are so scarred, they have all this collapse of the alveoli that you're not going to get back. You're already starting out behind the 8 ball, and you have to be extra cautious with them. So we have a few techniques that we can use to help with these specific patients. For our EMTs, airway adjuncts are well within the scope. If you're bagging one of these patients and you're having difficulty, use an MPA, use an OPA. You can use CPAP, or if you have BiPAP, you can use BiPAP. And then the last one here is one that I'm a big believer in, apneic oxygenation. Has anybody heard of this? I see the back row. This isn't really a thing that I've heard much in EMS. It's gotten really big in emergency medicine. I think that all of us at U of L do it now. And I don't know why it hasn't reached EMS quite yet, but
it's funny, normally things go from EMS to the ER, like EMS forces the change, and it's one of those very few.
Yeah. Yeah. It's really simple. All you do is while you're intubating the patient, put a nasal cannula on them and crank it up to 15 liters. That's it. And what this does is it creates an oxygen gradient. It's pretty theoretical, I'm not gonna lie. It's not, there's the evidence on it is a little bit, you have some great studies that show that it has some benefit. You have some studies that show maybe it doesn't. But theoretically what it does is it increases the oxygen gradient up in the nasopharynx and pushes it down towards the lungs and tries to keep that oxygen down in the lungs as much as you can while they're not breathing. So you're taking that safe apnea time and trying to extend it. Is this gonna give you an extra 2 minutes? Probably not. But in this COPD patient who you're already working with 30 seconds of time, is this gonna give you 45 seconds? Yeah, it's definitely not gonna take any away, and I don't think there's much of a downside to it. How I get this set up when I'm getting ready to intubate a patient is when I'm pre-oxygenating the patient, whether you choose your non-rebreather, you can even put it under a CPAP or BiPAP, put the nasal cannula on them and just turn it to 2 liters. And then as soon as I pull the non-rebreather off or the bag valve mask off, I crank it up to 15. And I just leave it there the entire time. Pro tip, it's a little bit hard if you're using the end tidal, just because it then dangles in front of the mouth. At that point, you can cut it off. So, any questions about this? It's super easy, and I like to think that it's saved me a good amount of times.
The communication is key, because it'll always, without fail, if I do it myself, put it on, and then give the drugs, and then RT comes in and they take it off. Right when I go in the mouth. And I'm like, and we don't have time to like go discuss it.
Yeah.
And so I always have to, shared mental model is so important with this, because somebody's going to take that needle cannula out every time if you don't talk about it.
Yep.
So saying to everybody, I'm putting the nasal cannula in because I'm going to pre-oxygenate, or apneic oxygenate, I think is important to say that out loud.
All right, and that gives us our last 2 big pitfalls. For getting apneic oxygenation, I do it on everybody. I don't care if I'm intubating a 21-year-old at this point. I've just kind of made it my habit, and it's something I do, and it's something that the team knows that I do. So that way when I do have the sick patient, I'm already freaking out, I don't forget about it. And then not predicting risk. In these high-risk patients, make sure you're initiating pre-oxygenation early and be extra aggressive with it. Get to the 100%, don't accept, these are the patients that I especially try not to accept 98%. I want to get all the way to 100%, or at least that full 3 minutes before I try anything in their airway and stop their breathing.
Do you have any problems with that with smaller adults because of like secretions and stuff like that? Because we very seldom see 100 on children who have like RSV.
You mean like getting up to 100%?
Yeah.
Yeah, I mean, I can't always get them up there. I try my best, and there's definitely some times where, you know, we've hit 94%, and I know that that's the best we're going to get. We've been going for 5 minutes. But I think the big thing that changed my mindset was in a lot of these patients, you don't need to take their airway in the next 30 seconds. It's what we freak out and what we rush to do, and we think, oh my God, I have to intubate them right now. But you can wait 5 minutes if you have to, and make sure that you really pre-oxygenate them to make sure you get that first time success. Now, if you're going for 5 minutes, you've got them on CPAP, you're doing your apneic oxygenation, yeah, you probably just got to go for it at that point. And it's definitely a situation I've been in more than once.
The best I learned was when anesthesia paralyzed somebody, and we just sat there and watched, and in like 3 minutes, and I was like, you sure we don't need to do anything? He's like, no, look, 100%. Anyway, that was the VA, wasn't it?
Yeah.
But it was crazy, because you would have thought that, you know, we all want to be like, oh no, we gotta breathe from him immediately, and you know, he was doing just fine.
And you all can probably see this too in like, I think Luke gave us a case of a young, obvious brain injury patients. These patients are otherwise healthy. You may get that with pre-oxygenation a good 6 minutes where that patient doesn't have to breathe, and you can take your time with intubation. But I think intubation in general, rushing it has always caused me more problems than it has helped me. Any other questions? That's right. All right. Thank you.
I appreciate it. You do 5 minutes while I get the sim set up, and then what I think we can do is one at a time. And take 5 minutes. Figure it out. All is fresh.
So back home, having conversations like, yeah, they were,
What's up, man? How are you? I haven't seen you in forever. I know. When I walked in the room, I was trying to figure out why you look so familiar. And then as soon as you put your name up there, I was like,
I subscribed for him back when he was at UL.
yeah,
Hey, man,
Jeff, nice to meet you. I'm medical director of Frank Creek.
okay. Yeah, I've heard your name.
Yeah, I did residency and I did the EMS fellowship
Yeah.
as well too. I work at Norton right now. But actually, I'm going to be working a few shifts at UL, so I might see. I think I work a shift. Yeah, my first shift is the 20th of this month, and then I think I have one in November, one in December, and then we'll see where it goes from there. Cool. So you're going to be with me next month?
Yep.
All right. Well, be gentle with me. I've been working at UL in 7 years now, so obviously know the medicine stuff, but all the process stuff is massively changed since when I was there, from what I understand. Yeah, that's what I've heard.
The option is the only thing that's changed.
Cool.
Now,
Sorry.
Yeah.
And where are you coming from?
So we were in school. We went to DePaul.
Okay.
This man went.
Did you do
I did
residency?
I did residency at U of L.
Okay.
And then, took out the same car that you probably were in.
Well, actually, they got that after I left.
Oh, did they?
So I was the first actual fellow. The fellowship program had existed on paper for, I don't know, 2 or 3 years, but I was the first one to use it. And they didn't have a vehicle for it at that time. But I got it from one of the fire departments.
Yeah.
Because I became their medical director with starting the fellowship.
Okay.
And so they got me a vehicle, so that's how we kind of worked it out. But I think it was 2 or 3 years later. Yeah, they got the vehicle, which is I think pretty cool.
Yeah. Yeah, like I said, I've heard your name. In regards to the fellowship.
Where are you going next year?
Back home. I'm from Mississippi.
Oh, okay,
So
cool.
I'm going to go back. Hopefully, in the process of signing a contract. Corinth, Mississippi.
Okay, sweet.
So
You got some EMS work lined up?
Yeah. Fall back into a medical director spot.
Cool.
Places and services I used to work for.
Oh, that's
So,
pretty cool.
yeah.
Yeah, that's pretty cool to come back as medical director somewhere you used to work.
Still the same people there. It's just I go home and hang out with all my buddies.
Nice.
Right.
What are you doing next year?
Hopefully.
Well, thank you,
take a
Tracy.
loop.
I appreciate
Cool.
that. And I will,
We'll find out next
you'll be very happy to look.
I know,
Do you wanna, look at me now.
I only applied.
You deserve to look.
I,
So you guys-
You're staying here no matter what.
It might be
Not
here.
doing
Well,
anything.
okay.
Yeah, dragged around 3 times in the last 4 years.
Yeah, that's usually how it goes.
Yep.
Yeah, no problem. Yeah, and we'll just let them know that after that, then we're gonna go back to normal.
I'll see you around.
Oh, wait, he's in Lithuania.
Perfect.
Yeah, right.
Thanks, Tracy, appreciate it.
Correct. Crazy, you're about to.
Yes, I did go to Lithuania with my graduate college.
And,
I mean, as far as like the actual pushing the buttons, but awesome. Like I said,
so, they wanna run.
Were you at
I think
McGowan?
we'll break it up into
How
like
we-
2 groups maybe.
Because you all were the first batch.
And then we have our Oldham County, they,
Yeah, we're gonna see class.
Do you wanna do groups of 3?
And actually, Evan,
Or do you wanna do groups of
men's
1?
class.
I wanna make sure you get hands-on.
Are we doing like 15-minute iterations?
Yeah, 15 minutes.
Okay. Let's group of 3. I just make sure I would have a paramedic to mine. We don't have everyone.
Yeah, you have
Yeah. Well, you know, I mixed things like super good ones like you. Amazing. Like, I would read my notes after the end of the shift, and you would have put in like, echo results from 6 months ago that I hadn't even looked at, and I was like, damn, I sound so smart. But some of the ones that weren't good, it was like more work than if you just done the note yourself. So it was really, really very good. You know, and when I went to Norton, I didn't know how much I would or would not miss having Scribe, but honestly,
No one's noticed. I just like
pretty easily not having one. Just because, like you said, the bad ones took away time, and there weren't enough good ones like you. It was mostly
That's what they were. They took them away mine.
yeah.
And I think saying the same.
Oh my gosh.
I want to make this more
The one thing, you know, the one thing it would be good for was like those shifts where you just spend the whole shift and so at least when
I don't understand. I live in Fisher, so I'm still in Jefferson. I'm like, you go to Shelby County and turn around and go back into Jefferson. That's where I was. Which drives me nuts. Much lower if I was just. Not even a mile, like 500 feet.
Oh. Yeah, just don't Shelby County.
I'm right there. I'm right on the border. I know. I thought I was, and then I got the deed that said Jefferson. Son of a. Yeah, exactly. Still use the library though.
How can you still use the one?
Oh, I'm 10 minutes from Wild.
Oh, well, so I live in That was great.
So I appreciate it. I can.
You know what I was thinking? Since nobody specified the date.
People may come. Yeah, we have a lot tomorrow. I don't know. I hope.
you know, from what I can tell, I think
Never EMS is like involved in the way they're kind of coming and going.
Oh, that's a really good point.
And then, you know, I know they.
That is a really good point. Doing points and patches really matters.
What everyone in this industry cares about.
You know what? I'm gonna have to figure out who that
I
person
don't.
is.
It's his thing. From what I understand, they're just taking our protocols. That's the only thing they're doing. Like, actually, he's gonna do everything else. Yes. Not been impressive. Impressing me.
There was like 6 of them that showed up. They're about ready to be ready and they were trying to see what our system
And then let's do respiration.
Sorry, you got away.
And then SPO2.
Easily take our system, shove it over there.
I'll do that.
No matter how high risk
Prognosis.
we're hitting our fields this week.
Austin Baker.
So we could have done the whole thing, already have everything set up. So there's like, we could do it for less than 5 hours. I don't know what their process is. It really, no, that's not that, because Jeremy went to like the fire chief's meeting, like, why are you so successful?
Oh, sweet. And then is,
Why did you
still
invite an EMS only services on top of
That's it.
fire chiefs? You're always gonna do a fire chief. You're not changing.
Last I heard, Chelsea Peterson is
Carlisle.
So I've got them for Malbec already. For Miles.
Oh, yeah.
Actually, might not be a bad idea for us.
yeah, I saw. He's the only one I really
Let's make it.
Yeah, no,
Let's make 40 and let's
the improv. Last I heard, he was at the VA.
You want to do
we retaining?
that was the first.
We can have a big
Still like it.
So he moved up to North Carolina pretty soon after residency, and I was trying
How long are we?
Ryan is still doing actually
10 minutes, 15 minutes.
randomly ran into him.
15 minutes. Ish. He's a movie.
Yeah, so
She's funny.
He's got me here now, right?
So even the instructor, you get a chance.
Oh, okay.
He's
I
got
thought he was
skateboard.
Sorry.
Yeah, I know. I'm excited. I'm excited.
We're going to loop first.
yeah, so we're gonna
Deploy the first times and
we're gonna get Luke warmed up.
We're getting EMS in Louisville that we're doing.
He's got
We're going to share. We're going to share.
we'll wait for them.
Yeah.
Trailers off. Thanks, zippers. I learned that. Sorry, Jimmy, come back first.
You know, where I work now is.
Yeah, we'll do the adult.
So basically, we have, you know, 2 or 3 docs that do.
With you guys, this one.
Oh, no, we won't.
They did already this year.
Yeah, you should. You know, I think some of
And then it came back and it was like.
recently we got Brett Nelson.
You know what, it was either, it was in June, Matt. It was in June.
I believe getting there.
Yeah, that's right.
It was in June.
I love this.
No.
I love this. How do you even know trucks?
Yeah, it's really neat. I think this is the coolest.
Is this the escape room?
It is. Yeah.
I mean, it's just.
Yeah,
can you
Scott
imagine?
County up in Indiana had one of these when we went up to do sales. And I'm like,
Donna, this is
That
the
was
escape
all
room.
COVID weirdness.
You do that next. We get to see.
Okay, you guys save your patient. We're ready. You get all 5 of us.
You wanna start with them at 10:30? You wanna start with them at?
You know, when I first took the job, we were.
You have till.
Karen's like.
10:45. Then we'll
That's pressure.
Remember those
Oh,
times
yeah.
that you
Oh,
were-
sick as shit. Yeah, she should.
Abilities are and what we've got going on here.
What monitors are you all comfortable with? Cardiac monitor. Zolex? I can make the skin look like a Zolex.
I was like,
So anything on here, fair play. If you don't know where something is, you can always ask, and I'll direct you. It's like a typical ambulance. Some things will look nice because nobody touches them. Other things look like, well, the last shift didn't clean up. So for this guy, he's actually breathing. You can see. Okay, so be sure to do your assessment. If you want to palpate a pulse, you can palpate a radial, carotid, and femoral pulse. You can also auscultate in all your fields. You can get abdominal tones, or abdominal sounds, and heart tones.
okay.
So
Pulses, yeah.
you can intubate him if you want to. You can use supraglottic airway. He will ventilate. You can do CPR. He does have more capabilities, but for today's scenario, we will not.
Yeah, we're looking for the backboard.
You want a backboard? Backboard's over there.
Yeah, we'll
You want
switch
to
it for
administer
you.
oxygen? Your oxygen administered.
Yeah.
If you want to use suction, suction's
Thank
right
you.
here.
I think I feel it like once and then I like.
Not the medical.
Yeah, right, yeah.
So, and that, what's really interesting about this sim tool is the boundingness of the pulse is proportional to the blood pressure. So I can, on the back side, set the blood pressure really low, and it'll be a very weak pulse.
Everything that you see still are used, central pulses. No, you won't need to use anything.
Yeah, I mean, I can override it and essentially make them go away. Femoral, carotid, and left radial. Not for this model. I mean, it's got the skin forward, it's got the little cutouts in the feet, but not this particular one.
And you'll have to use the tools to go through.
This is the one you and I carried in that room that time.
I've got the practice teeth in, so you know you don't really have to break them. But this guy, I can switch out with actual. They look like
We'll say we're at
appliances.
we'll
You
say
can really break them.
Yeah, like chicklets.
Chicklets.
Thanks for not
Beth just said she's not intubated in a long time.
Beth,
so-
you need to make your way around to the top.
We'll give you the airway seat.
Karen wants it.
Yeah, true. Karen just intubated a head yesterday.
Yeah.
Yeah, it's just a pre-established line.
Okay.
We use something similar.
So you are going to be the first one. I've been sitting there after I got done with my lecture. I was given I was trying my best to think of a good scenario. So.
ER.
You didn't plan this for the last
Donna and I.
2 weeks. She has a.
Oh, he's throwing up, ladies. Oh, wear your gloves.
Oh, he's already out there starting it. We're sitting there chit-chatting.
So.
No, that is
Yonker.
breathing.
Yonker.
So you've responded to a 24-year-old male complaining of shortness of breath. You get to a park and you find him. You find him laying on the ground.
Is that supposed to be notable of hypoxia?
I find him laying on the ground.
Did you just stick your finger in his?
So
pupils
hold
are
his
three
tongue
reactive.
forward.
He's awake and
But
talking.
yes, he
He's
is
awake and
Do we
talking.
have drugs?
Appears to be very.
Okay, he is on the monitor
Is he
now.
any trauma to his head?
Do we have to put him? Oh, okay.
No,
This
he's
is a very
like I said, he's
nice
alert and able to
job
answer
you've
questions.
got.
It is.
I'm gonna go look for one for her. Can we get him on oxygen?
Yeah. And then,
Looks like Fox.
can we
This
give
is too
him?
much for me.
Okay, you all do over
You
here.
said he was unresponsive,
He
correct?
can, no, he can answer questions.
Talking.
Oh.
Yeah, okay. Did you fall?
No.
Oh. He actually fell.
No.
No, he did not fall. So what's going on today?
I don't have a.
Okay. He said I was out walking. It was the first cool day that we've had, and all of a sudden I just got to feeling really short of breath.
I don't know if that's where that's supposed to
Is
go.
he vomiting or is that like he can't breathe? I don't know. Listen. Here, Karen. Listen to it. I'm looking for a non-rebreather.
He's just
Audible inspiratory.
he's just saying I'm just really having
Does he have
trouble.
hives all over him, urticaria or anything like that?
Now listen, you quit that coughing in my face.
Is he having stridor or is he wheezing, Karen? What's your go-to stats?
For a certain finger.
They're putting him on a ladder.
Yeah, I hit it, but.
She didn't
Oh,
hit
there
it. It
is.
didn't work.
It's 130 over 82.
Okay. Pulse ox.
Pulse ox is on.
What's Mayim Epi? Is he
Hey,
equal?
just so you all know, he has
Is
unequal pupils.
Wheezing as well as having
He should have.
Is that,
he
can we
equal?
give him
Okay.
some
I was
IM
like,
Epi?
he has
Can we
unequal
give him
pupils.
0.5 milligrams of IM Epi?
His pupils are unequal.
You want 0.5 milligrams of IM Epi. Drugs appear to be behind my friend Miss Amy over here.
Non-rebreather is on.
Listen, this looks like a good thing to have nearby just in case.
Okay, what about our history? Is there pupils really? Is there any family members with him?
His pupils are supposed to be equal.
So I'll be a family member.
Okay.
So this has happened before. He ran out of his inhaler about a week ago.
Sounds about right.
So he was doing,
Oh, it's
but he was doing
albuterol
okay. We were
too?
gonna get to the
IMFE.
pharmacy to go pick it up, but we just decided to come out, and it was just such a nice, cool day that we decided to come out and walk around the park.
Do you guys have IM Epi?
There it is.
So, we're gonna give him albuterol and give him about 20. Sounds good.
I need a.
So you have an
Gosh, I
upset.
need to open all this stuff.
He said it's fair game.
I know, man. Here's some albuterol. Okay, albuterol. Albuterol.
So he's also currently trying to stroke. He's trying to sit up and trying to like.
Well,
He's just
so
wanting
set
to,
him up, make him more comfortable. Come on, bud. What's his name?
his name's Jerry.
Jerry. Dude. All right, take deep breaths, Jeremy. Jerry.
Hey, how about we go ahead? You're going to give some IM Epi. Where's the hell?
You said 0.5 milligrams, correct?
No albuterol under it. It says albuterol. There's no albuterol.
We give him a liter LR.
All right, I did something wrong. Oh. Do these switch out? It's exciting to actually open stuff. I know. That's why I keep. Here's some albuterol. This is racemic,
right
here.
His stats are 71. Is there a certain place you want me to give
How much
IM?
albuterol is this batch?
It's
It's 2.5 at each, that's 5.
Okay.
She said verbal.
Oh, verbalize it. Okay, IM epi is in.
Okay. Albuterol, 5 milligrams is started. Racemic. I've never seen racemic in that, so. Here.
Thank
Throw
you.
some
Switch him
racemic
out.
in it, too. We can pour some epi in it.
Does he have a waste for his fluids?
You can mix it. Can you put fluids in?
No, it's not hooked up right now.
Okay, just
lock
for-
it off and send it.
Alright.
We do need to figure out, we probably need to give him some steroids of some sort.
Yes.
Sure.
What'd she say?
Do
Okay,
you have
Bob.
Decadron?
Listen to him again, Karen, see if he sounds better.
We have Decadron.
Albuterol,
Solumedrol.
Decadron.
We have Solumedrol. We have Window and Decadron.
No, he's not a pee. They like
He's not, yeah, they like Solumedrol. 125 milligrams of Solumedrol.
Yes, ma'am.
You got the
Are these syringes over there? Yeah.
Okay.
Heart rate's obviously going up.
Needle.
Stats are improving a little, but we're still upper 70s. We're cycling under pressure.
So we have the albuterol and the racemic going.
So let's
Is he
recap.
awake? Let's reassess. Is
Hey,
he
Jerry.
awake?
Jerry, you feeling better?
Hey,
Is he
no,
still awake?
not really.
Not feeling better?
I don't feel a ton better, no.
Okay.
He's not
Did he
blue
tell us that?
Listen.
anymore, and he's not. Okay,
Yeah.
no trauma. No, he said no trauma.
No
No
trauma, out of
Okay.
his meds.
The pupils
All right,
are
the-
a red herring.
Pupils,
Yeah.
yeah, so
Yeah,
I
this is-
assume the albuterol is just blown into his right
He's
pupil.
He's
That
got.
can happen. Is Decoria?
Yeah, I've got I've got
Okay.
physiologic antipsychotic. I've had it my
All
whole
right.
life.
You had what?
Wheeze sounds
And
better.
Okay.
They sound equal.
No, I said you had
I
it
don't
your
think he
entire
has a
life.
pneumo. His
Huh?
chest rise
Okay.
is
Yeah,
equal.
yeah.
Is his trachea midline?
Albuterol.
All right, I didn't get to put the receipt.
Okay,
He's like,
Solumedrol.
Love it.
So he did albuterol, racemic, Solumedrol.
We got a liter of fluids
and I am
running,
his inspiratory, I guess, wheeze is better.
but
and
his
his
mentation
stats-
is poor.
Mentation is 4.
He's still able to answer questions and talk, but he just still looks significantly distressed.
Can
We, after that albuterol, we can put him on
Nah,
a
man, this is
BiPAP.
just like the last time this happened.
Did he?
He's like, yeah, this.
Has
this
he ever
happened.
been on a ventilator?
He said, yeah, I've been on. They've had to intubate me before. He said, but you know, he's like, I really don't want that if we can.
Okay, did
But-
anything work? Did you ever do CPAP?
Do they
BiPAP.
Do you
What
have
is-
a
what is
BiPAP
that?
in here?
BiPAP. The mask is going to go
Oh,
over
the
your
big
nose.
mask that makes it where I sound like Darth Vader. Oh yeah, yeah, I've had that before.
He's been on
Well,
BiPAP.
I've been hitting this, but not doing
I have a
anything.
mask, but do we have a ventilator or?
It might be a dirty screen, but it should cycle if you hit it.
Do we have anything in here we can hook this up to?
Do we have anything that we
What's
can?
BiPAP. He said he's been on
So
BiPAP
all we have
before.
is all we have is a CPAP in here, but you can hook it up. Let's see, do we have the tubing and stuff for it somewhere?
How's his,
I have a mask.
how's his mentation, Luke?
So
Is
he's still awake answering questions.
Okay, because his stats are steadily coming up. Like coming up to 86. He
Deep
was started out
breaths,
at
deep
72.
breaths. You're doing good,
How's
Jerry.
his respiratory? His blood pressure is now 159 over 117. Do you have any history of hypertension, Jerry?
I don't think so.
No
Get a
meds.
Muffy.
Are you on any meds, Jerry?
I'm supposed to take my breathing treatments,
Yeah,
and
shocker.
he said I forget I ran out like a week ago. That's the only thing I take.
Okay.
Oh.
Any allergies to medications?
No.
Okay.
Now listen, in the peace world, we'd be slapping fancy tape on your face to protect your skin and everything.
Yeah.
In
that's
the
true.
adult world, y'all are like,
All right, so this is done. Putting him. All right. Just take deep breaths. You're going to feel like you're
Going
suffocated
through
a little bit.
wind
Especially with
tunnel.
But
no
he
air
says
through it.
that he's been on this before and it helped. So we're just going to do it like you did last time.
We're gonna start you at a PEEP of 5. That's what that is on.
Did you just put it on it?
Right here,
Maybe
Amy.
Move your finger down.
I'll pretend that's it. It looked like a
hell
peep
does
of 5
that
to me.
work?
Donna, can you move your finger?
Oh,
You
sorry.
gotta get the back of it down. It's hanging back
I
here.
was going to say, why don't we use something that easy as this? Alright.
We use a ventilator.
I know, but this is so much easier.
Well, they were 89, now they just dropped to Asheville saying 86. Are we gonna have them?
We're passenger
Alright, I'm gonna
princesses
hold this
and-
on.
Yours has got hooks
So
on it.
his stats are slowly going down even though we get to know how
I have
you
it.
all the way up.
Okay, so do we have?
Can we
Oh, God, I
run
don't like
albuterol
this.
through this?
You don't like
You're
it?
pretty uncomfortable. How
Take
about
it.
we give you something to make you a little more calm?
You give him some
You
Ativan?
want to give him some Versed or Ativan?
Inline?
Sure.
You wanna do an inline?
Yep.
Show you how to do it.
You want to give him?
Oh my gosh.
You want to see if there's Versed or Ativan back there? We can give Jerry something to
Hey,
make
we
us
got
feel
some,
better.
we have a, can I give him 2 grams of mag sulfate too?
That's not a good seal.
No.
He's still wheezing, Karen? Give him 2
All right,
grams of mag
so we've
sulfate.
continued albuterol. We've given him.
2 grams of mag sulfate.
All right, we're on a PEEP of 5.
This wheeze is better. Is iteration better?
How much,
No, his saps are worse. They're 81. Alright, so give him the mag. You can give him another IMF.
We can do another. Yeah, give him another
Hey,
IM.
is he okay? He's not really opening his eyes anymore. Hey, Jerry, hey, buddy.
Hey,
God,
Jerry.
he's gonna kill our patient.
Yep.
They want us to-
All right,
Amy, can you
His heart rate is
prepare
not going
some
up.
medication
Prepare
for intubation?
I have a
Give
second
him
dose
another
of
epi.
IM Epi.
Okay, and then we're going to put
So,
his head of the bed
We're
down.
giving
guys.
another
We're gonna-
dose of IM Epi now.
Can you attempt to recycle a blood pressure, please?
I will
And
recycle
we're going to
blood
have to
pressure.
start
We need the bag.
bagging him.
There is no.
And
Point out
bag.
that we did not assign roles.
We
We
did not.
did not.
Okay, Karen, who wants to bed? How about you're the team leader?
No, Karen can be team leader. I'm gonna intubate.
Okay.
Beth's
Here
gonna
is
have
Mag.
airway.
Well, Beth needs to come get airway then. All right, here's mag sulfate.
Okay, what's your job? I have minimal jobs where
I
You wanna
am.
do it? I don't care.
I'll be ready for this.
Yes, yes.
You can come back up.
So monitor. Do you
Hey, just
have
so
a
y'all know,
female?
speaking of that, his heart rate is 60. So,
Yeah, he's not a.
you ready?
He's not a kid. He's
Not
not
a
a kid.
kid.
I know, but I'm waiting. His stats are 50.
Are you bagging him? Does he have a pulse?
Yes, he's not. We need a tube. Can you grab a tube for her, please? Grab a 8.
What size?
8.
I don't feel a pulse. Do you feel a pulse? Okay.
What,
8:30
it says his heart rate is 60 some. He's gonna have a pulse and his heart rate is 60 some.
Then you get over here and feel one,
Eight.
boss.
Well, I'm just saying he's not a kid, so he's gonna have his heart rate is 60. He's gonna have a pulse.
Eight cup. I got an 8 cup right here. And then what size blade do you want?
I already got the blade up.
3 max. You already got it?
Yeah.
3 max.
Somebody get me this epic, please.
I do not. Donna, does Donna have?
Yeah, you can hand that to me.
I need a milligram of epi.
I got it.
Meds. I'm doing equipment.
I need to count.
29.
Here,
I'm trying.
I'll take this.
Suction.
Hey, do we need to spray this at all because he's mannequin?
There's
Third or
blue
fourth?
up there next to the IV bag, see it on the left? Green jelly.
Oh, you guys don't have a spray? Ah, you want to put?
That's 4 rounds.
Okay.
Water
We're gonna do a
based
pulse check after this, Donnie. Get me some. We always have, we have a spray. We can spray it before.
He's going in.
Sean, is the trachea still midline?
It is.
Thank you.
Yep.
Pulse check. Hold on.
I have suction.
Okay, now what are we over here?
Count me down.
Okay. Oh, we need a shot. You got a pulse?
What are we? I didn't feel a pulse.
He's gonna be checked. Please shock him, please. 2 joules. These are pads. Okay, we're not in an ambulance very often. Where's the pad?
What happened to my dad?
Here.
What are you all doing? Help!
Listen,
something.
we're gonna find you a chaplain, but it's not right now. What other drug?
Pad. Pad. Keep doing CPR. Yep.
Dragging too fast for an adult. Pad. Alright, reset. Yeah, what do you get it at?
I don't know how to use that
150. Yep.
There you go.
Charge. Oh, it's supposed to be charging, did it not?
Did you go to that? Sorry.
Charge. There we go.
Charging. Keep going, Donnie. You're crushing
I
it.
am.
We've moved to continuous,
Charge.
right?
Clear, clear,
Clear, clear.
everybody clear. Shock.
Remember how I
Shock
said it-
delivered. CPR.
Increase it to Jules, please. Would somebody get me a somebody needs to listen, make sure he hasn't blown a pneumo.
Alright.
Where's
So we'll go ahead. We'll go ahead and sign.
Okay.
So you can tell us how bad we suck. We killed him.
We killed him.
Jerry was never going to make you guys. I'm sorry.
Oh gosh.
Take care of small children
It
for
was
a
me.
living.
Well, they don't make it either.
No, they're not the same.
They
Sean.
always
I don't
say
care
that
what you
children are
say.
small adults.
They are not.
No.
No.
We do not agree with that
And that
literature
salty
at all.
paramedic dude who says that, I want to throat punch him. Because that ain't true.
And I will point out the adult placement of the pads. Strong work.
There you go.
Zoll actually favors even for adults anterior.
It is because
Yeah.
we get CPR feedback off of it, so you do the AP.
I
Yeah.
got your old CPR feedback too. You want to see it?
Probably not. Not at my best. My FRC's for sure low.
We're not deep enough.
Yeah. Okay. Listen,
We're not fast enough.
the last time I wrestled a patient that was large was about 2 weeks ago, and I still don't like him right now, and I didn't have to do CPR.
Is that worse than Starlet?
Oh
And my elbow got
gosh.
off when I was trying to bag.
What was our end title?
No clue.
You work
Because
for
we didn't put
EMS.
one on.
That's what you all do
I
all
can
the
care
time.
less.
We say this
Move
every
the
time we
entitle
do
up.
simulation.
I don't care.
We're like, y'all are so good at entitle. We have
So with recovery of entitle, tell me about it, because we don't use that for children. For recovery.
Oh, okay. So for like your end title, if you've got a high end title, we know we've got a ventilation or a perfusion issue. So some of your treatments are going to be titrated based on that. So if you're bagging,
We
you
normally
might
would
need
have
to
put one
slow
in.
down, or you might need to speed up just a little bit. And I don't mean like 50 times a minute or 4 times a minute, but are we breathing 8 times a minute?
On recovery from CPR, like once we get,
Oh.
because I've
I think
had
he just
EMS
meant
people
we
say,
didn't use it at all. I
Right.
think that's what he's
So,
saying.
Yeah.
in EMS, we can do side stream monitoring. So if you have a conscious patient, you can see the different bronchospasms, you can see the effects of albuterol just through a nasal pen.
We do have entitled nasal
Yeah.
cannulas, and we
You're actually
do-
going to get a VQ mismatch though, so I don't know.
You were talking about post arrest?
Just
No,
with
I think
asthmatics.
just with albuterol itself, you're talking about. If the end title goes, in my experience, like if the end title rises when you have an asthmatic who you're treating, you don't know if that's a good thing or a bad thing, because if there's such a gradient between your PCO2 and your end title because of bronchial constriction, it could be good, right, as your end title becomes more normal, or it could be bad because they're dying.
Yeah. What do you think about this guy? In the clinical
I got
context
it.
of
Yeah, in this
CO2.
guy, well, with
Mental status.
desaturations, mental status change, then he's in respiratory failure proceeding to ventricular failure. Maybe the albuterol, he had an underlying heart history that we didn't get, and suddenly he's in wide complex ventricular rhythm. And so the interventions could have made it worse and better at the same time.
It's potential. So this was going to be just a gentleman who had severe asthma exacerbation.
Let me see if they're.
So he's going to go down to a respiratory rest. Like I said, it was one of the things. I just wanted to kind of walk through all of the steps of just like a stepwise approach of an asthma exacerbation. You really call it bad. It's not something EMS sees.
Here's your bag.
A ton, as far as like proceeding all the way down the steps to intubation, but it is certainly something that happens. So it's something I want to run through with them just to kind of all encompass office. Again, this was a scenario that I made while I was sitting out there after doing my lecture, so this was.
So just so you're aware, when we go out, we preach, don't intubate an asthmatic.
Yep.
Don't
Oh, yeah,
intubate an asthmatic,
absolutely.
Don't intubate an asthmatic.
Absolutely.
But in our sims, we do intubate it.
Exactly, and
Yeah,
that's,
we do
and that's the
intubate.
thing, is that's gonna be part of the debrief, is don't intubate the asthmatic.
Now, anybody who watches it and comes in on Wednesday knows exactly what to do.
You do. Go back, and we'll talk about.
I do have a question. So his stats were like 85-86%. I would not have expected him to arrest at 85-86%.
Probably some of this.
Okay.
No,
That's why I was like very confused. I'm like,
Yes, that is.
Like I said,
I'm not sure why we've arrested.
Y'all are the test room.
We're the guinea pigs?
Y'all are the test
Gosh,
So long.
and our CPR sucks.
Oh, did it give you the quality assessment?
Did he have all his teeth?
Of course.
Because he does not anymore.
He doesn't?
Why don't you check the run report and see if what was documented?
He's missing two.
Karen, your husband would be so
sharks
ashamed.
out?
He's a physiologist.
Do we have any
I can't
sharks
wait to
out?
tell him.
We gotta get that. We gotta.
I try to keep
when
you
I
all
do simulations
congregated
and
right
stuff. A
here.
lot of EMS, we're like, yeah, we don't do like
You guys are
chest
Since
pretty,
Luke spent that whole day
speed
with
break.
Karen and I in the
Yes.
in
Yeah,
Oxford.
I know, but they were like cleaning up. Do
Oh, take your time.
checks
Whenever you are ready,
and
already
we wait
ready.
for our entitle to come back.
I try
What do
to
you
keep
all
them all.
think?
So,
We've had several tell us that.
I have not heard of entitled
Yeah, they've told us that a couple of times.
Have y'all
And
heard
when
anything
Karen
about
and I,
entitled being?
yeah, when Karen and I've come back, we're like, we
As-
need
as
to
an
ask
adjunct, for
people
sure.
who
Yeah.
are, the
Just kind of if you notice like a huge
The recovery.
difference in your all of a sudden.
With this,
Yeah.
you can see
well, and she's
entitled
asked them like,
waveforms, so you can see like a bronchospasm.
well, how, your end title is gonna be
Just making
crap what
words
you're
up, by the
doing,
way.
so, like, how,
Bronchospasm or.
how do you know? And he was like, well,
You can
we
listen
just
to
leave the
his
waveforms
lungs and
back
he's
like this.
bronchospasm.
I was like,
We're a very
I
big
didn't know if
component
I'd
like
ever heard that
look at your
before.
patient as opposed to
Look at a monitor, yeah.
From 10 to 35 and he's talking pressure.
All tools.
They're triggered to watch, to
You
stop.
can see if you've got
That's a That's a great,
all the
like,
entitled
hey,
things.
No.
I like the waveform.
something
No,
changed,
I
something
know.
happened, but as far as
I'm not
like
saying I'm against
looking
that.
for
What did
that.
you say? What did he talk
You
about?
don't,
Saying.
you don't use a lot of it.
Where have we heard this?
What you all usually
Okay,
use, I wish
yes,
adults
yes.
would
I'm sorry, I
use
didn't
is,
hear the question.
The heads up CPR.
Yeah,
is okay.
I was curious if maybe the
I like
heads up
those. I think
CPR
those are
device
cool.
had like
Yeah,
made
I mean,
that
that
side by
is
side.
get down
Sounds
on
like no.
intubation.
No.
But I've never heard of that.
They're
We'll have to-
implemented.
we'll have to delve into
Probably
it.
talked about it on the way back, I'm like,
Backwards. So,
alright,
You
you
rarely
really
need
need
that,
to
do
clean
you?
up your mess.
I know, I'm like cleaning up, but we're going to the escape room.
oh gosh.
I really enjoyed being able to put the medicine in the airway.
Yes.
Gosh, I
All right.
took,
Escape room, Donna had to take off her coat.
You guys
absolutely,
put medicine
man.
in the airway?
Y'all
Is that
identified
what I
like
heard?
what was going on pretty quickly as far as, this was a severe aspect.
Alright, there's a cap to this that,
You ready to escape?
Oh, we're ready.
Oh, I threw all the needles away.
well, when that
Oh, I don't
is-
know where that is. I did not touch
It's
that.
gray. I threw it.
You all got the first run, so you got to open everything.
I know, I popped it.
This thing?
Oh, here it is, here it is. I knew that I had thrown it down here, so.
Thank you.
And that thing, thank
You
you.
off the plane?
Yes. It's pretty good, y'all did it on the fly.
Yeah, I'm actually using two different computers to change
To do this? Oh
and
my
this.
gosh, I'm impressed.
I don't know about impressed, but
No, I am. We do simulations all the time. That takes a lot of, doing the computers and doing two of them at the same time.
yeah, there is a way I can pre-program scenarios in.
Yeah, that's
So-
what we do, so,
With a bunch of if
I'm
thens.
impressed.
Doing it on the fly.
I know, I love that. I love that. I guess I better get my,
Like I've got some things that I think will make it a little bit school. Yeah, it's
So
great.
they have the ability to put a headset on and just talk through the patient.
Yeah.
Which I think I have one at home that'll work for you guys. I'll bring it in.
You got an Xbox?
No, it's not Xbox, but I think it has the right plug.
You know, if that's the case, literally you and I can go sit in my office.
Yeah.
And we can see
I don't have
a
it here
play.
today, unfortunately.
And you know what's funny? I saw.
Alright, I'll give you some time to.
Yeah.
Casey had told her.
How did you think it went?
I think it went pretty well. Yeah, no, I think it went pretty well.
I think part of any sim is people are like, do I open it? Do I not open it?
Yeah, oh yeah, pulling the trigger on actually like using the meds and
Yeah,
What do you
I
all wanna
came
do?
up with this on the fly. Plus tied a knot in that. So they can't push it through there. It just goes back in the bag.
Goes back in the bag. Oh, yeah, that's a good idea. Throw these away.
Yeah. Okay. I think we got plenty, if not.
Yeah, there were samples each. Where is she?
That's what I told her when I was there the other day. I was like,
What is this?
All right. I know. I didn't even notice that. That was awesome.
Oh, did they strap it in?
They use this to actually hang the bag.
And they made it work. That is the most EMS thing ever. Just make it work.
they've already got 3. He's already there. He's old.
All right.
That's what, my niece has a 4-year-old and
Cool.
Yeah, this is cool.
in August, yes.
That was fun.
They were 32-weekers, not to add any more for us,
They had one of these at ASIP this year that was a mobile one that they drive around. You just pay like your
Health Force?
one-time fee. Yeah.
When
And they can just drive this up to your hospital.
When I went to paramedic school, we had one of these, but it was not as. It was just basically a shield in the back of the truck.
Yeah.
And when I was doing my checkoffs at the end, I intubated the guy, and he was like, the mannequin was still talking while he's like, I can't breathe. It's like, you're intubated.
Yeah, you're in the gut there, Bubba. You see an ET tube somewhere?
Oh, you're sitting on it.
Oh, okay. Yeah, yeah.
There you go.
Somebody find me my ET tube.
All right.
8. Wow. The pediatric doc put an 8 in?
Let's get it.
Gangster.
We're gonna do it. We're gonna do it.
Good Lord. What we got over here? Like we meant it. There's that.
Not a medical one, but we've
There's not near enough cabinets.
No.
Yeah, this is cool. Let's see if we can undo things here. Take the blood pressure cuff off. And the pulse ox and storm back in here.
We don't have a room to escape in there, but find a key that means at the end of the escape room that you can unlock it. Everything that you can see only gives you once, with the exception of the mannequin, yes, but and that is only used once, and then it should proceed every case through the cases. Anyway, it's up to you to figure out what case is first, which it is. You'll have 20 minutes to complete the airway escape room, and you'll have the opportunity to ask for 3 hints. For that.
sorry.
Okay.
Any questions?
I can't read upside down, so it's good.
3 hints.
3 hints.
Everything is these boxes and this.
Yes, just here. All that you see here. It's not nothing. We don't have the turntable.
Okay.
It's
Okay.
just limited to this
I
scope
have
here.
no idea what this structure is.
That is for the mannequin. That we can say that's out of plane.
Okay.
Okay.
Okay, so
Out
we
of-
need to
out of
read
sight.
this first.
Yep. Whenever you're ready, and I'll start the timer.
Those are clues.
Those are the clues.
We'll start the timer.
Do we
Okay.
got?
Timer started.
From breath to tube, the sequence must flow. Airway's the key, as every medic should know. Start with the basics, then tools in your hand. Oxygen next, before tube takes a stand. Order the steps, don't miss a beat, only the right sequence. Set your patient free.
ABCs.
So,
Okay,
do we
ABCs.
take this first?
Monitor and secure the tube, reassess formation,
Do we open all of these?
do whatever we want.
I don't know.
Oh, it says re-oxygenate the patient.
Oh,
That
we
says
have-
7 on it. This is getting us our code.
Yep.
Confirm tube placement.
Okay,
So
so
we
put
need
them
to
in
put
order.
this in order. So,
Uh-oh.
but also our patient stats are 82.
Reoxygenate. Oh.
We have a 70-kilo patient with our stats are 82, our blood pressure is 82/60, and our heart rate is 133.
Pre-oxygenate the patient.
Okay.
So Matt just told us we should be doing that while we're doing equipment.
7-1.
All right. 7,
1,
4, 7, 1.
Why is there 3, 4?
And so there's something with 4 and 4. 7, 1, 4, 7. Wait, is it?
This is 7028.
No, your 7s are different here.
Oh, that's a 9, I'm sorry.
That's
That-
a
That is a
9?
9,
Oh,
that's my
okay.
fault, that's
Seven,
Dr.
one,
Amber.
We still don't have anything with 5.
7-1,
There's no
4-9.
locks with 5.
Just try 7-1, 4-9.
No, those are letters.
It's not that one. 1, 4, 9. We're not gonna get out.
So we need the bag. Try, I don't know, 174? 4-9?
This should be. Well, I mean, I was doing
I
what
guess
Matt
we
told
could
us.
do
Yes.
1, 7. Try
I
1,
did,
7,
1, 7,
4,
4,
9.
If you
Or
have 5
7,
numbers and a
4,
skip
9,
bridge,
1.
you have 5.
Do you tell them to get
7, 4, 9.
hints?
Yeah, they have 3 hints.
Okay, a hint.
You want a hint? Is there something about the shapes that's different?
One's a square.
One's a square.
1,
7, 9, 1. Man.
This is a square, this is a circle.
This one, it's this one. No?
1, 7, 9, no, wait.
You got it.
1, 7, 9,
I thought I
1.
did.
Oh, yeah, okay. Woo! Oh, we got an Ambu bag and another damn lock. Okay.
Is he unconscious?
We're gonna
We're not
check
gonna
and see if
We're
there's
not putting anything in
anything.
his.
He has a penetrating trauma.
Well, he
so-
does have a penetrating trauma, it's in the back of his throat.
Okay. Oh,
So we need McGill's.
What's that?
it's another.
He does have something in the back of his
Freaking
airway.
What is it?
So let's try.
We're probably gonna have
You
to
need a
shrink.
flashlight to see
I
it?
don't know, man. Is there anything in his mouth? Is there
Yep.
a clue in his mouth?
Yep.
Is there a clue in his mouth?
Some McGill's.
I do not have any.
Oh, no, wait, no.
I'm like, I got it. Why can't I do that, man? There's something in there, so we gotta get something out.
Yeah. Suction?
So
We
Turn
have
off the
suction?
lights.
So what is this kind of thing? I can't see the numbers, so you're gonna have to do that.
I know, I need.
We're looking,
Here, I'm gonna
we're
go
looking
ahead.
for, we're looking
I'm
for a
gonna-
blood spatter.
What do you mean?
Come on, Yellen.
Is there
You're
a
gonna
crike
do
in
that.
there?
What does that mean?
Is there a crike?
Oh, look, there's hidden
There are,
numbers.
there-
Look,
there
look.
are.
Okay.
Don't be.
Yep, okay. This one is a 1.
Like a 1.
A 2, backwards. Flip them
Flip
over,
them
y'all.
over. Okay.
Just remember, if you've already used the clue, you don't use it again.
1.
1, 2, 4, 5.
Okay,
There's
I'm gonna
three.
go ahead and bag.
There's 3 on the
I'm
back.
trying to bag.
That's not it. That thing
Okay,
is
try
locked
the
tight.
second. Try the second
Well,
box
there's 1,
over there.
2, 3, 4, 5.
Well, maybe they just numbered it over.
That is it, yes, that is
Oh,
it.
okay. Man. Okay.
Yeah, I'm like,
All right, we're bagging.
I'm willing to look at anything.
Yes, I'm bagging, but. You know how long I spent crawling in that, you don't.
It was
you
just
weren't
the
there.
one
You
that
were
was
there.
supposed to be in.
Okay, what about the square one?
Okay.
Insert an advanced airway. That's not an advanced airway, it really means.
I mean, I guess we can put a nasopharyngeal.
Are we not gonna knock?
No,
down-
don't put a nasopharyngeal in.
I don't know what to.
No.
But are we
We're gonna have
gonna,
a
it's not gonna clear your obstruction.
Fingers will.
Not,
No, she
well,
doesn't.
this is gonna push it down
It's just
further.
gonna push it down further.
But she might not want
Yeah,
us
I
to
wouldn't do that either until we get it up.
Okay. Ladies, we're very smart individuals. We take
So
care
I
of
think-
very sick people all the time.
I know, I'm like, y'all are seeing something Start obviously with we've the not. basics, then tools in your hand.
Is there anything I can
Okay.
do?
Oxygen next before tubes take a stand. Cause I'm thinking he needs a crate,
I would like
but we need to figure out why.
Laughing with you.
Yeah, whatever.
Yeah, yes.
Feeling one-sided.
Okay,
We
do
didn't
the,
use all of these,
do the shadow again. What's
The first group
did you-
only used one hint, just so you all know.
Oh, man.
Yeah, I'm not very good at these.
Technically.
Technically.
All right, well, I guess we need a second hint because we're gonna run out of time. So hint number 2.
Hint number 2, are there other equipment that the black light could reveal the code?
Is it on equipment? Is it on here?
The bag, is it on? Ah, 7173, damn
For shining the black light?
it. No, I said Flip the lights off. We were looking for blood spatter and everything.
It is a trauma patient, I guess. That's a good point.
Yes.
Okay, we're gonna have to kick it in high gear here, please. We're never making it happen. This
We're never making it out.
I'm gonna check on Hal.
Okay, so, our mannequin here really breathes, right? You can really do an airway assessment. You can also take lung sounds. You can listen to the heart. You can listen to the bowel. It has the ability that if you want to push medications, either IV or IM, he does have a procedure arm, and that is over here for the sake of the simulation. You just hook this up. You can push whatever you want to through it. Everything on the truck is in play, right? If you're unsure about where something is because you're not familiar with our truck, just ask me. I'll be more than happy to send it to you. Oxygen, we have oxygen. Suction, we have suction. And since we're ambulance drivers in here and not flight crews, we can, even have background sound if you want. When you're doing your assessment, you can feel pulses carotid, left radial, and then femoral. Okay. Your monitor here has everything like your monitor typically will. Blood pressure cuff. When you put it on, you can hit the NIVP here. It has end-tidal. It has pulse oximetry. It also has your 4 and 12 leads. Okay.
Some don't fall out.
If you need to charge or defibrillate, you can do it just like you would on a regular monitor. It does have pads in here. It does not really shock. So, questions? No?
Is he already gonna be in the back of the ambulance? Cause that's dope.
Yeah.
This is an intercept.